Hello everyone, a very good morning to all of you. So, am I back? Am I visible? Am I audible? Am I live? Can you see me clearly? Can you hear me clearly? Kindly someone from the audience give me a thumbs up in the chat box if I'm clearly visible, audible. I can see your chat. Anyone? Am I audible? Am I visible? I guess I am. So, I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today I am here to continue my series, that is Crash Course of Pathology for second Prof MBBS students. We have started this series few days back for the students who are going to write their university exam this year, after few days, this month, the second Prof. So for pathology, we have completed most of the portions of the pathology. The last portion which is remaining here is hemodynamics. So today here I am starting with hemodynamics. Basically in hemodynamics, the 5 topics are important, which comes for long question. In some university, the long question is 5 marks, in some of them is 20 marks, in some of them is 10 marks, whatever. Long question you have to write for 8 to 10 pages in your university exam. So 5 questions are important in the chapter, in the topic hemodynamics. So what are those? So I will teach you edema. I will start with edema, then I will come on congestion, hyperimian congestion. After that I will come on thrombosis, then embolism, and then shock. After that, ischemia and infarction is also there, but ischemia and infarction more important in CVS and systemic pathology, not here. So these are the 5 important topics we are going to take one by one. Maybe edema is a long one, it requires 20 minutes. Rest of the topic I will try to cover in 15 minutes each of them. All of them are important. You can secure one exam, one short question in your exam from this topic. I'm damn sure one of the question will be from these 5, but which one we actually don't know, right? So let me start with the first topic, edema, without wasting any time. Edema, right? What is the definition of edema? So I'm teaching you edema for a long question in all the points. So how to write it in your exam? Like this, right? So first define edema. What is edema? Can you define edema? What is edema? So actually this is edema. In Hindi, edema is known as sujan. Patient comes to you कि मुझे swelling है. In layman language, it is known as swelling. Swelling anywhere in the body is known as edema. So basically it is the swelling. It is the swelling anywhere in the body. It is known as edema, right? So how you define edema? All the body is made up of cell. The complete organs. Human body is made up of numerous organs, and all the organs are made up of cell. So you can see the cells. You can see this is a cell, this is a cell. It can be any organ of human body. What I mean to say here, the space between the cell. Can you appreciate the space between the cell? The space between the cell is known as interstitial space. Interstitial space. Normally, this interstitial space is dry. There is no fluid in it. If interstitial contains fluid, if fluid accumulate in the interstitial space, that organ swells and that leads to edema. So what is the definition of edema? Edema is defined as abnormal and excessive collection of fluid in the interstitial tissue space. You got what is interstitial space? Interstitial space is the space between adjacent cells in any organ. So the space between the cells is interstitial space, and if fluid is accumulating in that space, it is known as edema. So edema is the abnormal and excessive accumulation of fluid in the interstitial space. That is the definition of edema. You got my point? Now there is another term which is known as effusion. In human body, we have various cavities. We have pleural cavity surrounding lung. We have pericardial cavity surrounding the heart. We have peritoneal cavity, abdominal cavity, thoracic cavity. We have various cavity. If abnormal and excessive fluid collect in the cavity, not in interstitial space, but in cavity, it is known as effusion. Now, the pathophysiology of edema and effusion is same. You got my point? So basically, I am teaching you both. If the question is coming on edema, the pathogenesis is same. If the question is coming on effusion, the pathogenesis is same. The only difference, both of them are abnormal and excessive collection of fluid. But here, the fluid is collected in interstitial space, and here, the fluid is collected in the body cavities. Give me a thumbs up. So that is the definition. You got my point? Do you have any doubt? Edema and effusion. So if you have any doubt, please write down in the chat box. Edema. So that is the definition of edema. So you can see this is edema. This is edema. That is collection of fluid in the interstitial space. And you can see this is effusion. Collection of fluid in the pleural cavity, that is pleural effusion. Collection of fluid here, you can see in the pericardial cavity. Can you see the heart is surrounded by pericardial cavity? Appreciate this fluid. The excessive fluid in the pericardial cavity is pericardial effusion. So this is pericardial effusion, and this is pleural effusion. You can see it is in the pleural effusion. So that is effusion. So you got my point. What is edema? What is effusion? Now, before understanding the pathophysiology of edema, which is difficult to understand, you must understand normal tissue exchange. So first you write the definition of edema, you write the definition of effusion. Now come on normal tissue exchange, then I will come on pathophysiology of edema. Normal tissue exchange, I would like to draw a diagram for you. So here I would like to draw a diagram. Give me a minute. Can you see this is the organ? This can be any organ in human body. This is the organ. This can be, let me take another sheet. Just a second. Can be any organ in human body, right? This is any organ in human body. Organ, right? All organs are supplied by blood, that is artery. So this is the artery for that organ. This is the artery for that organ. Artery come, it get divided into capillaries. These are the capillaries. These are the capillaries, right? These all are capillaries for that organ, and capillaries leads to the formation of the vein. So this is the vein. So this is artery, this is vein, and in between these are the capillaries. Artery carry pure blood, right? And vein become impure blood. Have you ever thought how this pure blood becoming impure? After entering in the organ, how pure blood become impure? How it happen? What do you mean by pure blood? It contains oxygen. What do you mean by impure blood? It do not contain oxygen, it contains carbon dioxide. So what is the change happening? So something is happening in the capillary. So let me draw a capillary separately. So I would like to draw a capillary. So this is a capillary. So capillary, it is not artery, it is not vein, it is capillary. What I am saying, it is capillary. Now capillary arise from the artery. So from the artery, capillary is coming. So this is arterial end of the capillary, right? And it leads to the vein. Capillary leads to the vein. So this is the venous end. This is the venous end of the capillary. This is a capillary having two ends, arterial end and venous end. Give me a thumbs up. So same diagram. Can you see this diagram? In this diagram, I try to show a artery. The capillary is arising from it and it is leading to the formation of vein. Here pure blood containing oxygen. Here impure blood containing carbon dioxide. So something is happening in the capillary. I want to explain you that. How pure blood converted into impure blood for understanding the mechanism of edema. This is a capillary. In the capillary, see this is a capillary. This is the arterial end of the capillary. So pure blood containing oxygen enters from here, right? And this is the venous end of the capillary. So after becoming impure, the blood comes out and goes in the vein. So this is a capillary. This is a capillary. Now this is supplying blood to an organ. So this is that organ. Can you see? This is that organ. This capillary is supplying blood to this organ. These are the cells of that organ. Give me a thumbs up. These are the cells of that organ, right? This is the capillary supplying blood to this organ. Now you have to understand the pressures. There are two types of pressures in human body in the capillary. Hydrostatic pressure and osmotic pressure. What do you mean by that? The word hydro means it is due to water. So whenever water is present, this pressure is created. So hydrostatic pressure is the pressure due to water and it is always outward. It is outward. And osmotic pressure is the pressure due to protein. It is inward. It is inward. So in any capillary, in any blood vessel, two types of pressures act on it. The blood contains water, the blood contains protein. So whatever water present in the blood, that will push the fluid outside. That is hydrostatic pressure is always outward. It is due to water. And whatever protein present here in the blood, that will attract the fluid. So that is the inward pressure. See the arrow. And this is known as osmotic pressure. So hydrostatic pressure is outward. See the arrow. Osmotic pressure is inward. See the arrow. Let me talk about these two pressures in a normal human capillary, right? So whenever blood is entering here, it contains water, it contains protein. So at arterial end, the hydrostatic pressure is 38 mm of mercury. And it is 25 mm of right? So 38 mm and 25 mm. Give me a thumbs up. So these are the pressures at arterial end, 38 and 25. So hydrostatic is outward and osmotic is inward. Tell me which is more. 38, of course, it is more than 25. So 38 minus 25, it will be 13. So net pressure here at arterial end is 13 and that 13 is outward. Because 38 minus 25 is plus 13. It is outward. So can you see the arrows here? So the fluid will go out with 13 mm. 13 mm of pressure, the fluid will move out. Some of the fluid will move out and go here. It will go here to the organ, to the cells. That fluid is going everywhere in the organ, in the cell, in the interstitial space the fluid is going. That fluid contains oxygen. So all the oxygen is reaching here between the cells in the interstitial space. So all these cells will take the oxygen and they release carbon dioxide. They release carbon dioxide. It is happening everywhere here. Because of this, with 13 mm fluid is coming out and doing the exchange with the cell. Oxygen is given because it is the pure blood. Now it will give oxygen and carbon dioxide is taken up. Now the fluid is going out by 13. So while going here, the hydrostatic pressure decreases. Instead of 38 at venous end, the hydrostatic pressure is only 12. It is not 38, but proteins are not going out. So osmotic pressure is same throughout, whether it is arterial end or whether it is venous end. It is always 25. It is always 25. So tell me the physics at venous end. At venous end, what is the pressure? The two pressures. Hydrostatic, instead of 38, it becomes 12, but osmotic is still 25. So net pressure is again 13. 25 minus 12 is again 13. But this time, this 13 is inward. This is inward pressure because 25 is greater than 13 and 25 is the value of osmotic. So this 13 is the inward. So at venous end, see the arrows. It is the 13 inward. It is a 13 inward pressure. So the fluid is going out by 13 mm, does the exchange, and the same fluid again come in with 13 mm. That's why in the end, the tissue is dry. The tissue is dry means whatever fluid coming out, the same fluid after exchange comes in. So patient, usually person don't have edema. I don't have edema. You don't have edema. Normal healthy human don't have edema because we have this physics in our body. So this all reading, understanding is difficult. But at every moment, at this second also inside my body, this all is happening. In your body, this all is happening. So we don't have to, cautious about that. What is my hydrostatic pressure? What is my osmotic pressure at arterial and venous end? So this is all happening inside human body every time, every moment. This is the physics. Give me a thumbs up. So that is known as Starling's law. That is known as Starling's law. So at arterial end, the two pressures are 38 and 25. Hydrostatic is 38, osmotic is 25. So outward is more than inward. So with 13 mm, the fluid come out. So it will do the exchange. By exchange, I mean it is pure blood. It contains oxygen. So oxygen is given to the cell and carbon dioxide is collected from the cell, right? Now venous end, at venous end, since the fluid goes out, so instead of 38, only 12 mm is remaining. Water is decreased now, but protein is same everywhere. So protein, here also it is osmotic pressure 25. Here also osmotic pressure is 25. Give me a thumbs up. So here 25 and 13 are the two pressure. 25 and 12. So again, you do the difference, it is 13, but this time 13 is inward. So my point is that at arterial end, fluid goes out by 13 mm, does the exchange, and at venous end, the same fluid comes in with 13 mm. So since the balance is there, both pressures are 13, 13. At arterial end of the capillary, this is all capillary we are talking. At arterial end of the capillary, we have 13 mm of pressure outward. And at venous end of capillary, we have 13 mm of pressure inward. So with 13 mm, the fluid goes out at arterial end, does the exchange, pure blood convert into impure blood, oxygen is given, carbon dioxide is taken, and at venous end, the impure blood is taken back with 13 mm. So this is known as normal physics, normal Starling's law holding good here. And in the end, in the tissue, there is no fluid. With 13, it is coming, with 13 it is going back. So tissue is dry in the end. There is no edema. There is no edema. Give me a thumbs up. Now any changes occur in the pressure will lead to edema. You tell me the causes of the edema now. You can write it like this, right? So it is the hydrostatic pressure in the capillary. It is outward force, and osmotic pressure is due to protein and it is inward. These are the basics, the golden rule you should know, the two type of the pressure. So you learn the values. After learning the values, you can say it is the two type. At arterial end, it is 38 and 12. So the net is 13, and at venous end, osmotic is always 25 throughout the capillary. So this is the thing I want to tell you. At arterial end, 38 minus 25 is 13, and it is outward. And at venous end, it is 25 minus 12, again 13, it is inward. So whatever fluid coming out at the arterial, the same fluid going back in the venous. So in the end, the tissue is dry. The tissue is dry and there is no edema. There is no edema. So that is the thing. You got my point? So there is a balance. There is a balance at both ends. 13 mm outward, 13 mm inward. This is known as balance. That's why the tissue is dry and there is no edema. This is normal physics. Now still, if some changes occur, if instead of 38 it is 39, if it is 25 instead of it is 24, if some changes, minor changes occur, God has given a backup, So some small amount of fluid is collected here, no? If some minor changes are there, 1-2 mm changes are there. So some small amount, maybe the fluid is coming out by 14 mm and going back by 13 mm. So maybe 1 mm of fluid is collected here, or some minor fluid is collected. So God has given lymphatics. Lymphatics are present in human body in all organs. Lymphatics are the backup. They will take the extra fluid. So we have the pressure balance at the arterial end of the capillary, at the venous end of the capillary in all organs. Still, if some minor pressure changes occur and fluid is still collecting, even after such a beautiful balance, such a beautiful mechanism, even if some fluid is collecting, there is a backup. The name of the backup is lymphatic. So whatever extra fluid is collecting here is taken by the lymphatic. So lymphatics are the backup. So that is the lymphatics. Any excessive interstitial fluid still collected, that is taken by lymphatic, and ultimately it is dry. The tissue is dry. There is no edema. So you tell me, what is the pathogenesis of edema? No, you have to tell me. Either outward pressure increases, that is hydrostatic pressure increases, or inward pressure decreases, that is oncotic pressure decreases. That will lead to imbalance, right? So you want more and more fluid to be outward. So either you increase outward so that fluid comes out, more fluid comes out, and you decrease inward. So less goes back. So more coming out, less going back, so it will accumulate there. The coming out is more and going back is less. Currently it is a balance. Whatever coming out is going back. The fluid coming out with 13 mm, going back with 13 mm. So it is balance. If you want to make imbalance, if the body is having any imbalance, that is outward more and inward less, the remaining one will accumulate here and that will lead to edema. So the first two reasons, increased hydrostatic pressure can be the reason for edema. Decreased oncotic pressure can be the reason. Oncotic, osmotic is one and the same thing. So oncotic or osmotic decrease, that is outward pressure increase, inward pressure decrease. The third reason can be lymphatic obstruction. Both pressures are normal. Outward, inward, here also it is 13, here also it is 13. But lymphatics are obstructed. The lymphatics. So third reason can be lymphatic obstruction. These are the three main causes understood from the normal mechanism. Give me a thumbs up. You got my point. The next fourth is the sodium water retention. Sometimes all the pressures are normal. Outward also, inward also, hydrostatic also, osmotic also, and lymphatics are also open. Still patient have edema. Then you will have a question, ma'am, all the pressures are normal. The lymphatic is also open. Now, why the patient is having edema? In that case, the explanation will be sodium water retention. In that case, the kidney is not working properly and kidney is retaining sodium and water and patient have oliguria. Patient is not excreting urine. So all the water is retained by the body. That may be the reason. And the fifth and the last one, sometimes this is also not the reason. Pressures are normal, outward is normal, inward is normal, lymphatics are open, and so kidneys are normal. Sodium water retention is not there. Still patient can have edema. The last reason is the increased capillary permeability. What do you mean by increased capillary permeability? Normal capillaries are like this. Normal capillaries are continuous. The endothelial lining is continuous. So fluid do not goes out. The fluid and protein do not goes out. Sometimes in inflammation, there are gaps formation. In the endothelial lining, the gaps are formed. Formation of gaps. Can you appreciate these gaps? Can you appreciate these gaps? The gaps are formed. These gaps formation is known as increased vascular permeability. So the fluid present here along with the protein will go out and it will form exudate type of edema. So this is the mechanism here. Give me a thumbs up. You got my point. So these are the 5 reasons for the edema. So till now I taught you what is edema, the definition of edema. You know the definition of edema. What is edema? It is abnormal and excessive collection of fluid in the interstitial space of any organ. That is edema. Effusion is a related term. Abnormal and excessive collection of fluid not in interstitial space but in the cavity, the body cavity. So edema, effusion, same pathophysiology. But to understand the pathophysiology, this is the pathophysiology of edema also, effusion also. Whatever coming in your exam, if effusion is coming for 5 marks, write same thing. But you should understand normal. In the normal, I explained you Starling's law. In the Starling's law, I taught you 2 pressure, the hydrostatic pressure, oncotic pressure. Hydrostatic is outward. It is due to water. Osmotic or oncotic is inward. It is due to protein, right? At arterial end of the capillary, at venous end of the capillary. Here also 38 minus 12, the net 38 minus 25, the net is 13. Here 25 minus 13, the net is 13, right? So here net outward, here net inward. You got my point. So with 13 mm pressure, the fluid comes out at arterial end, do the exchange. With 13 mm pressure, the fluid goes back at venous end after doing exchange. So pure blood get converted into impure. The exchange takes place at cellular level. This is normal mechanism. You should be able. So there is a balance. Now if any imbalance occur out of the 5 reasons, it will lead to edema. So what are the 5 reasons of edema? Number 1, increased outward pressure. That is hydrostatic pressure. The first reason written in front of you. The second is decreased inward pressure. That is osmotic. You want the collection. So outward should be more, inward should be less. The reverse cannot be true. You say कि मैम inward ज़्यादा कर दो, outward कम कर दो, तो edema नहीं होगा. Edema तभी होगा जब outward ज़्यादा होगा, inward कम होगा. So increase hydrostatic pressure, number 1. Decrease osmotic pressure, number 2. The backup, the lymphatics are obstructed, number 3. Number 4, all 3 are normal. Still patient have edema, so it is kidneys are abnormal. They are not excreting urine. They are doing sodium water retention. So excessive water accumulation in the body that can lead to edema. Still, if all these are normal, the 5th reason is the increased vascular permeability in edema in inflammation. So the gaps between the endothelial lining can lead to edema in case of inflammation. Yesterday I taught you inflammation, the steps of the inflammation, the 5 vascular events, the 6 cellular events. Those who are my old students, those who have attended my inflammation lecture, they know the vascular event. What is the 4th vascular event? It is vasoconstriction, transient, vasodilatation, which is persistent. The 3rd one is increased hydrostatic pressure. What is the 4th one? Increased vascular permeability. That I am talking about the 5th mechanism. Increased vascular permeability, that is gaps are formed in inflammation that can lead to edema. In inflammation also I taught you the 2 type of edema, transudate, exudate. So this is how you have to correlate the chapters. Give me a thumbs up. So these are the 5 reasons. Now in each of them, you have to tell me 2 or 3 examples of each type. That's it. So edema is done. So in edema, only 3 things are important: the definition, the normal Starling's law explanation, and the pathogenesis of edema. In the pathogenesis, the 5 causes are in front of you. But for each cause, tell me the examples. Tell me some examples of edema in which patient have edema because of increased hydrostatic pressure. Tell me 2 examples. Jisme patient have edema. You are a doctor. Now patients are coming to you, you are doctor, you are practicing as a doctor. Patient will come to you with symptom. They will not come to you with diagnosis. Patient will come to you, doctor, I am having swelling. Any part of the body. It can be face, it can be legs, it can be any part. It can be throughout the body, known as anasarca. Complete body swelling is known as anasarca. It can be any swelling. For a layman, for a patient, it is just a swelling. But being a doctor, you should think the mechanism. Why the patient is having swelling? Because the treatment may be different in the 5 cases. Now, so the pathogenesis is important. You can't understand, yeah, swelling hai to ek hi treatment hai. No, you have to understand the mechanism. What is the mechanism of this swelling in this particular patient? So likewise, the treatment may be different. You got my point? So the first 2 examples of increased hydrostatic pressure I am going to teach you now. Increased hydrostatic pressure. The 2 examples. Let me start one by one. Increased hydrostatic pressure. So here the hydrostatic pressure is increased but osmotic is same. So outward pressure is more and inward is less. So outward pressure is more as compared to inward. Outward is greater than inward. So there is fluid accumulation, imbalance occur, and it leads to edema. You got the mechanism is not important. Important are the 2 examples. So what are the 2 examples? Heart failure. The first example is the heart failure, right heart failure, especially right heart failure. It can be left heart failure also. Heart failure is the first thing. And second is postural. I will explain you both. See, this is a diagram of heart. Can you see? Do right heart failure. In this diagram, can you do right heart failure? This right ventricle is not pumping. It is not ejecting. It is not pumping. Stop pumping. It stops systole. That the disease is known as right heart failure. How it lead to edema? Can you tell me? So blood is not going ahead. Normally, when the right ventricle is pumping, blood was going in the lungs for purification. It is impure blood, but it is not going in the lungs because it is not pumping. So it will go backward. The blood will go backward. Where the blood will go? It will go backward. Where? So from right ventricle, it will go to right auricle. From right auricle, it will go to SVC IVC. From SVC IVC, it is a vein. SVC IVC is a vein. So it will go to the veins of particular organ and it will go to the organ. It will go to the organ and organ will have, that particular organs will have edema. Why they have edema? Because there is more blood. Because there is more blood, because of the backward flow, blood is coming. More blood in the vein. More blood means more water. More water means more hydrostatic pressure. Because of which imbalance. Here oncotic pressure is same. For these organs, the oncotic pressure is same. Protein is not increasing, decreasing. It is still 25 mm. But hydrostatic pressure is increasing because more blood is coming by backward mechanism, because heart is not pumping. So by backward flow, more blood is coming, more water. More blood matlab more water, more hydrostatic pressure. So these organs will have edema. Give me a thumbs up. You got my point? So that is the thing. So in case of right heart failure, patient have edema of all organs of the body. It can be liver, spleen, all organs are edematous because of this reason. Do left heart failure. Do left heart failure. Left ventricle is not pumping. What will happen now? You tell me. Left ventricle is not pumping. So blood is not going in the aorta. Normally left ventricle pump and blood goes in the aorta. It is not going in aorta. So it will go backward. From left ventricle to left auricle, from left auricle to pulmonary vein. It is a vein. And ultimately it will reach to the lung. So lungs will have edema because the veins of the lung have more blood, more hydrostatic pressure, osmotic pressure is same. You got my point? So in right heart failure, patient have edema of all organs. In left heart failure, patient have pulmonary edema. That is the summary. Ultimately, edema in both heart failure, whether it is right heart failure, whether it is left heart failure, edema ka reason is increased blood. Increased blood means increased hydrostatic pressure. So increased hydrostatic pressure leading to edema in heart failure. So that is the thing. You got my point? So any heart failure patient coming to your clinic, if right heart failure patient will come to your clinic, the patient have edema in all the organs. If left heart failure patient coming to your clinic, patient have only pulmonary edema. Here patient have edema throughout the body. So patient have liver edema, kidney edema, various organs edema. Here patient have pulmonary edema, so patient complains of dyspnea. Patient will come to you with a complaint of breathlessness, dyspnea. So the reason for both of them is increased hydrostatic pressure. There is no problem with the protein. There is a problem with water. More water, more blood in the veins of that organ. So that is a problem. The second example is the postural edema. What do you mean by postural edema? There are some persons whose job is standing, like the traffic policeman, like teachers like me. I'm standing constantly and teaching you. So the persons who are standing for more and more hours. So the legs are there. In the legs we have veins, right? These are the veins of the legs. These are the capacitance vessel. These are very dilated, big veins in the leg we are having. And whenever we are standing constantly for many hours, so gravity pulls the blood. We have gravity now. We have read the physics now. Newton explained the gravity. So gravity is attracting the blood. So out of the 5 liters of the blood in human body, most of the blood is accumulated in the legs here due to the gravity. So blood is accumulated in the veins of the legs. More blood, more water, more hydrostatic pressure. So legs will be edematous. Those legs have edema, right? So the persons who are standing constantly throughout the day for many hours, they have edema in the leg. This edema is known as postural edema. What's the reason for postural edema? It is increased hydrostatic pressure. So can you tell me 2 examples of increased hydrostatic pressure? The heart failure, left heart failure, right heart failure, both heart failure, and postural edema. In both of them, edema is due to increased hydrostatic pressure. That is more blood, more water. Give me a thumbs up. Here in right heart failure, edema in all organ, more blood, more water. Here in left heart failure, edema in lung, more blood, more water. And here in postural edema, the edema will be in the legs, more blood, more water. Due to the gravity, it is pulled. So you can give the explanation for all of them. Give me a thumbs up. So coming on the second reason, the first reason is done. The second is decreased osmotic pressure. Now tell me the reasons or examples for edema. The patient have edema, but the reason is not increased hydrostatic pressure. That is outward pressure. The patient have edema because of decreased oncotic pressure. Tell me 3 examples. Can you tell me the 3 examples of decreased oncotic pressure? The reasons of the edema for which decreased oncotic pressure is there, right? So these are the 3 examples. Okay, let me show you. This is a blood vessel. In the blood vessel, the red dots are the protein. Can you see? These are protein. From where protein comes in the blood? Can you tell me this is a protein which is creating osmotic pressure or oncotic pressure? Oncotic pressure is due to protein. So this is the protein. This is albumin or protein. From where this protein is coming? What is the source? Can you tell me? You will say, ma'am, we eat protein in the diet. This is the diet. So in the diet, we eat protein and it get absorbed from the intestine and reach in the blood. That is the first source. So GIT is the one source. Intestine se absorption occurs. We know that. The second, liver also synthesize protein. Liver also synthesize some protein. It is also coming in the blood. So there are 2 sources of protein in the blood. Number 1, GIT, absorption, normal diet, normal dietary intake of the protein. Number 2, liver synthesis. Give me a thumbs up, right? What is the source of excretion of the protein? How protein is excreted out of the body? So both the proteins are coming in the blood vessel. After coming in the blood vessel, if kidney is damaged, then only it is excreted in urine. Otherwise, protein is not excreted. Normal human urine doesn't have protein. But if kidney is damaged, it is excreted in urine, right? That is nephritic nephrotic syndrome. You got my point? Now tell me 3 reasons for decreased protein in the blood. If the protein in the blood is decreased, oncotic pressure will decrease and it will lead to edema. Tell me the 3 reasons. The first reason can be intestinal disease, malabsorption. Patient is eating properly, but intestines are defective. The cells of the intestine are not absorbing it. So protein will not reach here. So malabsorption is the first reason for decreased oncotic pressure. The persons having malabsorption have edema. The reason for the edema is malabsorption ki wajah se protein is not going in the blood. It is not absorbed and patient have decreased oncotic pressure. Blood is normal, water is normal, but protein is less. That is the first reason. Second, liver disease. Liver, patient is eating normally, absorption is also normal in the intestine, but liver is damaged. In the patient, there is alcoholic patient and there is cirrhosis. Liver is damaged. Liver is not synthesizing protein. Again, cirrhotic patients have edema. The reason for the edema is liver damage. Liver is not synthesizing protein. So patient have less protein in the blood, less oncotic pressure, normal water, normal hydrostatic pressure, less oncotic, normal hydrostatic. That can lead to edema. Give me a thumbs up. The third, the intestine is normal, absorption is normal. Liver is normal, liver synthesis is normal. Still patient have less oncotic pressure, less protein. So kidney is abnormal, it is excreting the protein in the blood. Patient is eating protein, liver is synthesizing protein. Both the proteins are coming in blood. From the blood it is excreted in the urine. So again in the blood there is low concentration of the protein. So osmotic pressure or oncotic pressure is less, hydrostatic is normal. So this is known as nephritic syndrome and nephrotic syndrome. So in nephritic syndrome and nephrotic syndrome also patient have edema. The reason is this. Give me a thumbs up. You got my my point? So these are the three reasons. The three reasons are written in front of you. The first is the malabsorption, that is problem in the intestine. The second in the problem in the liver, that is severe liver damage or cirrhosis. The third problem in the kidney, that is nephrotic syndrome. So in these three patient will come to you with edema. Okay, till now what we have learned, a heart failure patient can come to you with the edema, left heart failure, right heart failure. The postural, the patient who is standing constantly, the traffic policeman, the teachers or others, they are coming to your clinic, I'm having edema over the legs. So in these two persons, the reason for the edema is increased hydrostatic pressure. These three persons will also come to your clinic. A person having intestinal malabsorption, Kwashiorkor, PAM, you know, intestinal malabsorption. The person with cirrhosis of the liver, right? And the person with nephrotic syndrome, they also have edema. But the reason for edema is not hydrostatic pressure. Here, oncotic pressure is less. Inward pressure, protein is less. So the reason is different. The patient के लिए तो सब कुछ edema है. वो तो एक ही कंप्लेंट लाएगा, डॉक्टर साहब सूजन हो गई, कुछ करो, right? So for you have to understand what is the cause of the edema, right? So heart failure also leads to edema. Liver failure also leads to edema. Kidney failure also leads to edema, right? So whether the patient have heart failure, it is edema. Renal failure, also edema. Kidney failure, also edema, right? And liver, so these are the three vital organs which are damaged. The third is the lymphatic obstruction. Tell me three examples here where the patient have edema due to lymphatic obstruction. So this edema is known as lymphedema. I will give you three examples here. So you can understand lymphatics are the backup now. If the pressures are normal, hydrostatic is normal, osmotic is normal, still patient have edema because the lymphatics are obstructed. So there are three examples. You know, whenever any patient, female have a breast cancer. Can you see this female is having a breast cancer here? This is the breast tumor. You are a surgeon. What you will remove? You will do the surgery now. For all cancers, it is a malignant breast cancer. It is proven on biopsy. What you will do? You will remove the tumor in the breast, right? That is the main surgery. You will also remove the lymph nodes, axillary lymph nodes, because breast cancer most commonly do the lymphatic spread. In the last lecture in neoplasia, I taught you carcinoma spread by lymphatics. So you are doubtful whether lymph nodes are also involved. So you will remove all that. So you will give two incision. Number one incision, you will take the tumor out, main tumor. Number two incision, you will give incision in the axilla and you will take these also out. So ठीक है, tumor निकालना तो जरूरी था. We have removed the tumor and okay, and here we have removed the lymphatics. What was the job of lymphatics here? Why God has given lymphatics in the axilla of all human? We all have lymphatics in the axilla now. So why God has given these lymphatics to us? To prevent the edema. These are the backup now. You are removing the backup. No, it is necessary, right? It is necessary. This female will come to you like this after few years, after few months. So the side on which the breast surgery is done and the lymphatics are removed of which axilla? See the edema in that arm. It is very common complaint post-op. So this is the morbidity of the surgery. It is a morbidity or side effect of the surgery, you can say. But it is unavoidable, right? We have to do it. If we don't do it, you will say, ma'am, remove only tumor, don't remove the lymph nodes. If you don't remove the lymph nodes, the same patient will come with metastasis after few months, stage 4. We cannot afford that. She can die, right? So to prevent the life, we have to remove the lymphatics because it is already involved by the tumors. And if we are removing it, this is the morbidity. Patient have to live lifelong with this morbidity. So give me a thumbs up. This is known as, this is the reason here, lymphedema. So the reason you can write like this: removal of the axillary lymph nodes in a radical mastectomy in the carcinoma of the breast. So patient have edema of the affected arm. I have shown you the diagram also. Yes. So that is the first reason. The second, you can see in the legs we have lymphatics, right? In the legs we have lymphatics. Sometimes a parasite is there. Can you see the worm? Can you see the clusters of the worm? The parasite, the clusters of the worm. The name of this worm is Wuchereria bancrofti. Wuchereria bancrofti, right? It causes obstruction in the lymphatic. It is forming a cluster there and causing blockage of the lymphatic. So although lymphatic is present in the leg, but it is obstructed by the worm. The name of the worm is Wuchereria bancrofti. So what will happen? Lymphatics are not functioning. They are obstructed. They are present, but they are obstructed. So the patient will have edema of that leg. This leg is looking like an elephant leg. So disease is known as elephantitis. Elephantitis, हाथी पैर, हिंदी में कहते हैं हाथी पैर. So it is an example of lymphedema. Give me a thumbs up. Everyone give me a thumbs up. So that is the second example of lymphedema. The third example, sometimes congenital lymphedema is there. Congenital or hereditary. Hereditary, God has given defective lymphatics in the child. All the lymphatics in the child are defective. So complete body is edematous. Because all the lymphatics are defective, it is hereditary given by the God. It is not an acquired disease. The hereditary lymphedema is known as Milroy disease. So I have given you three examples. The three examples are in front of you. The first is the breast. The breast cancer surgery, axillary lymph nodes are removed. The second is Wuchereria bancrofti, that is filaria, causing elephantitis of the leg. And third is Milroy disease, that is hereditary lymphedema. So these are the three examples of the lymphedema, right? So the fourth reason is sodium water retention. we have explained the three causes of edema till now. The reasons for increased hydrostatic pressure, that is heart failure and postural. The reasons for decreased oncotic pressure, I taught you three things: intestinal malabsorption, liver failure, and kidney failure, right? Nephritic syndrome. Then I taught you lymphatic obstruction. In lymphatic obstruction also I have given you three examples. One is breast cancer ki surgery mein removal of axillary lymph nodes. One is Wucheria bankrupti obstructing the lymphatics of the leg, and third is Milroy disease, that is hereditary lymphedema. Now I'm coming on the fourth reason: sodium water retention. Both the pressures are normal. Hydrostatic, it is normal. Osmotic, it is normal. It is not increase, decrease. Lymphatic, it is open. It is not obstructed. Still patient have edema. Why? It is sodium water retention. So sometimes the kidney is abnormal and kidney is doing sodium water retention, right? And that can lead to edema. That is, due to sodium water retention. Due to renal failure, it is sodium water retention, and that can lead to the edema, right? So that is the thing. And last one is increased capillary permeability. As I have told you, increased capillary permeability, you can see the diagram, beautiful diagram from the Robbins. See, this is a blood vessel. See, in the blood vessel, these are the endothelial cells. Appreciate the continuity here. Please appreciate the continuity of the blood vessel here. And sometimes during inflammation, see the blood vessels here. See, they are discontinuous. You can see the gaps here. If you can appreciate the gaps here, these are the gaps. So from these gaps, the fluid and the protein coming out. The fluid is coming out, causing edema, and protein is also coming out. So decreased oncotic pressure, increased hydrostatic pressure, both lead to edema here. So this edema is exudate edema. It occurs in inflammation. So there are 5 reasons for edema. I have discussed all of them. Give me a thumbs up. Now it can be generalized, it can be localized. Inflammation wala. Generalized edema is throughout the body edema. It is known as anasarca. Anasarca, throughout the body inflammation is there, right? And localized edema is due to a mosquito bite. Localized, whenever mosquito bite to us, we have a local edema. So have you ever thought why we have edema? Mosquito bites us some phase of life. You may have experienced a mosquito bite now, so you have an edema at that pinpoint edema. Have you ever thought what is the mechanism behind that? This is the mechanism. So edema, this is localized edema. So it can be generalized, it can be localized. Generalized edema is anasarca. So I am done with the 5 causes of edema. They are in front of you. Can you tell me what are the 5 causes of edema? Increased hydrostatic pressure. The 2 examples are heart failure and postural, right? Decreased osmotic pressure. The 3 causes are liver failure, kidney failure, and malnutrition, right? Lymphatic obstruction, I taught you 3 causes here also. Number 1, breast cancer, axillary lymph node, filariasis, elephantitis, and Milroy disease, right? Sodium water retention is renal failure, and inflammation it can be generalized like anasarca or localized like mosquito bite. Everyone give me a thumbs up. The 5 causes of edema is done from my side. Now the last thing is the type of edema. There are 2 types of edema: exudate and transudate. Very, very important. This separately come for 2 or 3 marks in your exam. What is transudate edema? What is exudate edema? What is transudate? What is exudate? Okay. See the diagram. See, can you see the 3 diagrams? I will explain you. See, this is normal. Can you see this is normal? In this normal diagram, see the blood vessel. In the blood vessel, can you see the continuity of the endothelial cell? The endothelial cells are continuous with each other, and the yellow dots are the protein. These are the protein. And see the 2 arrow. Outward pressure is hydrostatic and inward pressure is osmotic. Robbins is a great author. See in the diagram what he has shown: a blood vessel with continuous endothelium with protein inside, and see the size of the 2 arrow. One is outward, that is hydrostatic. One is inward, that is osmotic, and size is equal means the pressures are equal. So there is no edema. In the background, you can't see any edema. See the second diagram. In the second diagram, still the blood vessel made the endothelial cells are continuous. There is no gap. They are still continuous. And protein is present inside. But see this arrow and see this arrow. So author wants to say, Robbins wants to say, the hydrostatic pressure increased due to any reason. The hydrostatic is increased or osmotic is decreased, right? Either hydrostatic increased or osmotic decreased. Compare the arrows. This one is increased, this one. So outward is increasing, inward is decreasing, but the cells are continuous. Endothelial cells mein gap nahi hai. So can you appreciate only fluid is coming out? See the arrows. Only fluid is coming out. So no gap. So fluid is coming out because outward is more and inward is less. Appreciate the edema here, the background edema. It contains only fluid, nothing else. Such edema is known as transudate edema. This edema is known as transudate edema. Now see the third diagram. In the third diagram, you can appreciate the gaps also. You can appreciate the gaps here. Please appreciate gaps. From these gaps, fluid to aa raha hai. Saath mein protein is also coming. Oh my God, protein is also coming. So in the edema, in the background, In the background, you are noticing two things. What are the two things noticing? Number one, fluid, and number two, protein. So this edema is known as exudate. So basically, transudate is protein poor edema and exudate is protein rich edema. Here, this one is protein poor, cell poor. No protein, no cell, only fluid. That is transudate. It is thin like water, right? And exudate is having high protein and high cell. Cells will also come here. The cells means WBC will also come out from these gaps. So protein rich, cell rich. This is pus. Basically pus, the thick white yellow pus, that is exudate. So transudate, exudate. Whenever you have inflammation in any part of body, to make a chot lagi. So initially, if you press it, a thin fluid comes out. That is transudate. But after few days, a thick yellowish pus is formed. That is exudate. So that is the thing. Give me a thumbs up. So what are the two types of edema? What is the definition of transudate? It is protein poor, cell poor. And what is the definition of exudate? It is protein rich, cell rich. Now you will never forget. Protein poor, cell poor edema is transudate. Protein rich, cell rich edema is exudate. You got my point? If you got my point, give me a thumbs up. If you have any doubt, please ask it. You have to draw these three diagrams in your exam. This diagram showing transudate and this diagram showing exudate. You should be able to explain in the exam that in transudate only fluid is coming, and in exudate along with the fluid, protein and cells are also coming. Because the gaps are there, and gaps are there in the inflammation only. When these gaps are formed, the gaps are formed in the inflammation only. Otherwise, gaps are not there. So can we say exudate edema form only in inflammation? Otherwise, there is no exudate edema. Normally, the edema is transudate, but in inflammation, the edema is exudate. So I taught you 5 reasons for edema now. So the first 4 reasons, that is increased hydrostatic pressure, decreased oncotic pressure, sodium water retention and lymphatic obstruction leads to transudate. But the 5th one, increased vascular permeability leads to exudate. This is the reason. This is the thing. You got my point? So that is the 2 types of edema. Now see transudate and see exudate. Tell me the differences between them. Who will tell me the differences between them? In transudate, it is non-inflammatory edema, and exudate is inflammatory edema. In transudate, the protein is less and cells are less. See, protein and cells are less. In exudate, the protein is high and the cells are many. Cells are many. So first write down the definition. It is non-inflammatory, it is inflammatory. Here protein less, here protein more. Here cell less, here cell more. You got my point? Give me a thumbs up. Here specific gravity is also less because protein is less, so specific gravity is also less. Here protein is more, so specific gravity is more. So protein, cell, specific gravity, right? All are less here. Not only this, LDH also. Here LDH is also less, here LDH is also more. Here LDH is also more. So these 4 things, protein, cell, LDH and specific gravity. 4 things are less in transudate and they are more in exudate. Only one thing is opposite that you have to take in consideration. See the pH. pH of transudate is more. It is more than 7.3 and pH of exudate is less. That is the one thing you have to take in consideration. The only thing which is more in transudate. Rest all things are less. pH is more here. You got my point? And one more thing, this edema is inflammatory ना. Inflammation कब होता है? जब बैक्टीरिया आता है. So background में बैक्टीरिया कहाँ पे present है? Background में बैक्टीरिया यहाँ पे है कि यहाँ पे है? In inflammation we have bacteria. We have bacteria. So see this diagram to explain the glucose content. Now this edema also contains, the background contains glucose and this edema also contains glucose. Whatever glucose present in blood, it is coming out here also. Glucose is coming out here also. So edema fluid contains glucose, right? Here glucose content is same as that of plasma. Here in transudate, whatever glucose present in plasma, that is coming in the edema. So edema mein glucose content same in plasma. Here whatever glucose coming out, it is the bacteria is present. Bacteria will consume the glucose. So glucose content in the edema in exudate, it is less than plasma because in edema we have bacteria. So the bacteria consumes glucose. Learn like this, you will never forget. So that is the concept behind it. Let me show you glucose content. In transudate, it is same as that of plasma because there is no bacteria. Whatever present in plasma coming in the edema. But in exudate, it is low as compared to plasma. You can learn like that the bacteria is consuming it because it is inflammatory edema. Inflammation mein microorganism is there. Give me a thumbs up. So I am done with transudate and exudate. Who will tell me the differences between transudate and exudate based on following points? Who will tell me the protein content of each of them, the cells of each of them, the LDH of each of them, the specific gravity for each of them, the pH for each of them, and the glucose for each of them? And who will tell me the other name given to this edema? So tell me the differences based on following points. Who will tell me? Can anyone try? Yes, anyone? Please start writing. So Tejaswini, yes, Ashwini, Kalma. So anyone? Cardinal August, Kuldeep, Aman. So protein, cell, LDH and specific gravity. These four things are less in transudate and these four things are more in transudate. So it is protein poor, cell poor, protein rich, cell rich. It is LDH less, specific gravity less, specific gravity and LDH are more. But the next point is the glucose, pH. pH is more than 7.3 here and it is less than 7.3. So pH makes a difference. pH is opposite, right? More or less ke मामले में, right? Glucose content, it is having same as that of plasma and here it is less than that of plasma as compared to plasma. You know the reason. What is the other name given to them? Other name given to them, it is known as non-inflammatory edema. And this one is inflammatory edema. I can write like this. Everyone give me a thumbs up. If you draw this complete chart with the proper explanation, you will get full 5 marks. So it will be a 3 marks or 5 mark question. I am done with edema. I am done with edema. The few important points, generalized edema is known as anasarca. Generalized edema is known as anasarca. In heart failure, the patient have dependent edema. What do you mean by dependent edema? In heart failure, the typical edema is dependent edema. So whenever the patient is standing, this is the patient. Whenever the patient is standing, where is the edema? In which organ? And whenever the patient is lying down, where is the edema? In which organ is the edema? The patient is lying down. Tell me, dependent edema. I am talking about dependent edema. So gravity always attracts blood, right? So cardiac edema is due to more hydrostatic pressure, more blood, more water. So here the edema will be in the foot, in the legs, and here edema will be in the back, in the genitals. So typically patient comes to you and says, doctor, whenever I lie down in the night and get up in the morning, I'm having edema in the back, but throughout the day my job is standing. So in the evening I'm having edema in the foot. So this edema is typically dependent edema and patient is indicating I'm having a heart disease, I'm having a cardiac failure, that is right heart failure. So it is the indication. Indirect indication, confirmation is done on echocardiogram, 2D echocardiogram, right? So that is the thing. Dependent edema is the term, right? And one more thing, in case of nephrotic syndrome, if renal failure is there, patient have edema in the body which is loose tissue in the body, such as around the eyes. Can you see? Typical edema around the eyes. So this is known as periorbital edema. Patient typically says, doctor, whenever I get up in the morning, my face is like swelling, and typically the swelling is below the eyes. So patient is indicating I'm having a renal failure. Renal failure edema is in the loose tissue, that is in the face, right? In the ankles, in the face, below the eye. So that is renal edema. So these are, indirect indicators of the what type of edema is there. Direct confirmation, you have to do other investigation. For heart, you have to do 2D echo. For renal failure, you have to see the GFR, you have to do the RFT, and you have to see other parameters. So this is all about edema. So if edema is coming for a long question in your exam, what you are going to write? If it is coming for 5 marks or 20 marks, what you are going to write? Who will tell me? Edema. If it is coming in my exam now, what I write first is the definition, not only of edema, of effusion also. I will write the definition of edema, I will write the definition of effusion. After that, I will write normal exchange, that is Starling's law. I will draw the diagram, I will say the values of hydrostatic pressure, that is 38, that is 12, and that is 25. The difference is 13, the difference is 13. But one is outward, one is inward at arterial, venous, and I have already explained you the Starling's law. After that, I will explain the pathogenesis of the edema, that is the 5 causes. The 5 causes: increased hydrostatic pressure, decreased oncotic pressure, lymphatic obstruction, sodium water retention by the kidney, and inflammation, that is increased vascular permeability. For each of them, I will give the examples, multiple examples. I have already given you the examples and explain all the examples. Not only this, in the end, I will write the types of the edema. I will draw a table between transudate and exudate. If I am doing all these, I will get full 20 marks. Not full 20, I will get 18, 19. If I am doing all these properly with drawing all the diagrams, give me a thumbs up. And if you start writing all these in your copy, you require 8 to 10 pages to write everything, to draw the flow charts, to explain every point, right? It is sufficient for a long question, is it? And if you are getting a short question, on any point, so you can get a short question only on definition, it will be a 3 mark or 2 mark question. Only on pathogenesis, it can be a 5 mark question. Only on the types, it can be a 5 mark or 3 mark question. Give me a thumbs up. So write that portion only. And if it is a long, write everything. This is the summary of edema. Give me a thumbs up. Everyone give me a thumbs up. This is the summary of edema. Everyone. One more important point I would like to explain here is the difference between nephritic and nephrotic edema. In the renal edema, there are two types of edema. Can we understand nephrotic syndrome mein edema and nephritic syndrome mein edema? In both of them, the reason for the edema is different. The reason for the edema is different. How I explain you, it is difficult, but still I will try. Still I will try. So let me draw a pair of kidney in nephrotic syndrome. What I am saying, it is nephrotic. Concentrate O, nephrotic. And here I am drawing nephritic. I guess you know the difference between them. If you don't know, watch my recordings of renal system. I have clearly explained the difference. Let me draw a pair of kidney here. And let me draw a pair of kidney here also. Pair of kidney here also, right? This is the ureters. This is the urinary bladder and urethra. Here also we have ureters. This is the urinary bladder. This is the urethra. So I want to explain you something. That's why I'm doing so much drawing. And this is the aorta. This is the renal artery. This is the aorta. This is the renal artery. Now see what is the pathogenesis and nephrotic. Nephrotic mein problem kya hai? Let me explain you the problem in nephrotic. In nephrotic, the kidneys are damaged with a disease. They are damaged with a disease, bilateral or unilateral, whatever. They are having various type of glomerulonephritis inside them. So they are losing the protein in the urine. This is the problem. All the protein present in the blood. Let me draw the protein. This is the protein in the blood. All the protein in the blood. Normally kidney don't lose protein in urine, but the kidneys are damaged. They have glomerulonephritis. So the protein is going inside the kidney and they are not retaining it. The protein is lost in the urine. So since the protein is lost in the urine, the blood is having less protein. Less protein, the blood is having hypoalbuminemia. This protein is basically albumin. Albumin. So patient have albuminuria. Albuminuria means all the albumin is excreted in urine. Albuminuria. Because of which patient have hypoalbuminemia. Albuminemia. So in the blood there is less protein. Less protein means less oncotic pressure. That is the reason of edema in this patient. In nephrotic patient, edema is due to less oncotic pressure. Less oncotic pressure. It is not increased hydrostatic pressure. It is less oncotic pressure. Give me a thumbs up. So what is the reason of edema in nephrotic syndrome? It is decreased oncotic pressure because the kidneys are damaged. They have glomerulonephritis. They cannot retain protein and they are excreting the protein in urine. So patient may albumin is excreted in urine. So blood have less protein, less albumin, less oncotic pressure. So imbalance is there. Hydrostatic pressure is normal. Outward is normal. Inward is decreased. So it will lead to imbalance. It will lead to edema. Give me a thumbs up. In nephritic syndrome, what is the problem? What is the problem here? How I explain you? The problem here is that the kidneys have ischemia. There is some problem in the renal artery. They are atherosclerosed. They have stenosis. They have spasm. One of the kidney or both kidney, they are receiving less blood. They are receiving less blood. The problem is that they are receiving less blood. Renal ischemia is the problem. They are not damaged. They don't have they have various type of glomerular, but basically the renal ischemia is the cause, right? They are receiving less blood. Whenever any kidney receive less blood, inside the kidney we have nephron, and inside the nephron we have a special group of cells. The name of the cells is GG cells, juxtaglomerular apparatus, that gets stimulated and it starts secreting renin in the blood. So renin will come in the blood. So the complete renin-angiotensinogen pathway will be activated and aldosterone will come. So renin will lead to formation of angiotensin 1. Angiotensin 1 will lead to formation of angiotensin 2. Angiotensin 2 will lead to the secretion of aldosterone. So ultimately aldosterone will come in the blood from the adrenal gland. And this aldosterone will do sodium water retention. Sodium and water retention. So urine will be less in amount. Oliguria. Patient have oliguria. Oliguria because most of the urine, that is sodium and water, is retained by the body. That will lead to edema. So what is the reason of edema in nephritic syndrome? It is sodium water retention. So give me a thumbs up. In nephrotic syndrome, it is hypoalbuminemia. That is decreased oncotic pressure. That is the reason. And in nephritic syndrome, it is sodium water retention is the reason. You can understand I tried my best. So you can draw the flow charts for nephritic and nephrotic syndrome to explain. So in nephrotic syndrome, edema is severe and generalized. The reason here is decreased osmotic pressure because patients have hypoalbuminemia. This is the cause of edema. But in nephritic syndrome, the edema is mild and it is not generalized throughout the body. It is only on the face, below the eyes, ankles and genitals, right? That is the loose tissue in the body, right? And here renal ischemia leads to renin-angiotensin pathway activation. It leads to sodium water retention. That is the reason of edema. You got my point? So you many times get the differences between nephrotic syndrome in your exam and you are unable to write. So these are the differences between nephrotic, this is O, nephrotic, and this is nephritic. This is I. Please appreciate the differences. Can you tell me the differences? Here it is nephrotic syndrome. Here it is nephritic syndrome. Here proteinuria is heavy and protein content is lost in the urine, right? And that is high. Here proteinuria is moderate, not much protein is lost, right? Here main cause of edema is decreased oncotic pressure. Here main cause of edema is sodium water retention. Here edema is severe. Here it is mild. Here edema throughout the body, that is generalized, visceral organ. Here edema is not generalized, only on the loose tissue, that is face, eye and genitals. You got my point? Edema is severe, edema is mild. Edema is generalized, edema is localized. Here the causes decrease osmotic pressure, and here the cause is sodium water retention. So we have done edema. What is edema? What is the pathogenesis of edema? What are the types of the edema? Give me a thumbs up. Everyone give me a thumbs up. We are done with the first chapter, edema. I'm not revising. We have completed it. Let me come on the second topic, hyperemia and congestion. You are interested for the second topic? Hyperemia and congestion. What is hyperemia? What is congestion? Both, the definition is same. What is the definition of hyperemia and congestion? Let me draw an organ. This is the organ. All organs, it can be any organ of human body. They receive blood from the artery. They receive blood from the artery, the pure blood. This is artery, and the vein takes the blood away. So this is the vein coming out. It carries impure blood and it is taking the blood away. See the direction. It is the coming and it is going. Everyone knows it. Everyone knows it. Now I will do two situations one by one. So imagine the arteries got dilated. The artery is dilated. What will happen? This artery is dilated. So more blood will come. So organ will have more blood. More blood. Organ will have more blood, and that is pure blood. Artery have pure blood. The organ will have more of the pure blood. So organ will look red, and this is known as hyperemia. Hyperemia is due to arterial dilatation. So more blood, more pure blood coming to the organ is erythromatous. It will become red, and it is known as hyperemia. Imagine the other situation. Vein got obstructed. Vein is not dilated, it is obstructed. Vein is obstructed. So blood is coming normally, artery is not dilated. So normal blood is coming, but it cannot go out. Impure blood is accumulating inside the organ. So again blood increase inside the organ. But this time the blood is impure blood. It is impure blood, right? That's why organ look blue in color, not red in color. So here the organ is not erythromatous. Here the organ is cyanotic, and this is known as congestion. So basically hyperemia and congestion, the definition of both of them is increased blood in the organ. Hyperemia में pure blood is accumulated in the organ. Congestion में impure blood is accumulated in the organ. Here it is due to arterial dilatation. Here it is due to venous obstruction. This one organ become red, erythema. Here organ become blue, cyanotic. Give me a thumbs up. Everyone give me a thumbs up. In your syllabus congestion is there. Hyperemia ka only definition is sufficient. So hyperemia and congestion. So you got the definitions of hyperemia and congestion, everybody. What is hyperemia and congestion? Definition of both of them. Hyperemia as well as congestion. Increase blood volume in the organ. Inside the organ. Increase blood. It can be pure, it can be impure. If it is pure, it is hyperemia. It is due to arterial dilatation. If it is impure, it is congestion, it is due to venous obstruction. Give me a thumbs up. You got my point. So you can see the same diagram is drawn. Hyperemia is due to arterial dilatation. That's why it is an active process. For dilatation of the artery, you require ATP, right? And here pure blood is collected. That's why erythema, right? That is the hyperemia. Congestion, it is venous obstruction. The veins are obstructed, right? And it is a passive process. It is a passive process, right? And the organ become blue, that is cyanotic, because deoxygenated blood is gathered. So you can see the differences between hyperemia and congestion. Hyperemia versus congestion. In hyperemia, it is an active process. Congestion is a passive process. Hyperemia, vasodilation of the artery. Congestion, venous obstruction. Here, oxygenated blood is gathered, that is organ is red or erythema. Here deoxygenated blood is accumulated, that's why organ is cyanotic. So these are the differences. In our syllabus, MBBS syllabus, we have to study congestion. We don't have to study hyperemia in detail. Hyperemia definition is sufficient. You should know the definition of hyperemia, good. But congestion you have to study in detail. Congestion again occur of two types, acute and chronic. Chronic one is important, chronic one. So it is known as CVC, chronic venous congestion, which is an important topic for your exam, CVC. So I'm going to teach you 3 CVC. Even students don't know the full form of CVC. It is chronic venous congestion, also known as CPC, chronic passive congestion. Anything coming in your exam, it is the same thing. Chronic venous congestion, because it is due to venous obstruction and it is passive. So chronic venous congestion or chronic passive congestion. So I will teach you 3 organs here. What 3 organs? Okay. Let's see a diagram of a heart. See. Can you do the left heart failure? Many times we have done it. So left ventricle is not pumping. So blood is not going ahead. It is going behind. The blood is going behind. It is going in the left auricle. From the left auricle, it is going in the pulmonary vein. From the pulmonary vein, it is accumulating in the lungs. It is accumulating here in the lungs. So it is pulmonary congestion. Here more blood in the lungs, but in the vein, it is the impure blood, it is more. You know, the left ventricle is not contracting, so blood is not going in the aorta. So it is going in the vein, pulmonary vein. More blood in the vein. That is technically vein is obstructed. So it is congestion of the lung. So this is known as CVC lung. In left heart failure, we have CVC lung. And in right heart failure, so blood will go in right auricle, it will go in SVC, IVC, and it will accumulate in all organs. So all organs it will be CVC. Especially I will teach you 2 organ, liver and spleen. So basically I am going to teach you 3 CVCs now. In left heart failure, you can see, in left heart failure, CVC occurs of the lung. In right heart failure, CVC occurs of all organ, but in our syllabus there are 2 CVCs, liver and spleen. So I suggest all the students to draw 3 CVCs with me. First I will teach you CVC lung, then I will teach you CVC liver, and then I will teach you CVC spleen. Expect one of the question for 5 marks in your exam, one of the CVC. So the 3 CVCs I am going to teach you back to back. You got the definition or the mechanism of the 3 CVCs. What is the mechanism? What is the mechanism? In each of them, tell the mechanism, tell the gross, tell the microscopy. Draw the microscopy. Draw gross and microscopy. You have to draw the diagrams. So how you will do? So for the lung, it is left heart failure. And for liver and spleen, it is right heart failure. Am I right? Am I right? Am I right? Yes or no? So left heart failure leads to lung CVC. And right heart failure leads to liver and spleen CVC, right? So I request you to make this comparative table so that you have a better retention of all CVCs together at one page. So before going to your exam, you can revise all CVCs. Expect one of the CVC in your exam. It is a very common, frequently asked question in the university exam. Write a short note on CVC lung, CVC liver or CVC spleen. All 3 will not come. One will come, but which one we don't know. So you should know the microscopy of all, right? Basically microscopy and gross. Let me start with the first one, lung. Gross and microscopy, right? So let me start with the first one, lung. Lung, liver, spleen, 3 CVC. Chronic venous congestion or chronic passive congestion. Shall I start? I'm starting CVC lung. In the gross, write down only one word. What is that? The lungs will become brownish in color. I will tell you the reason for the brown also. Brownish induration of the lung. So in left heart failure it occurs. In left heart failure, blood is not going ahead. It is going backward, and it is accumulated in the lungs. That is CVC lung. That is CVC lung. That is brown induration of the lung. That is brown induration is the gross. If I cut this lung and make a slide, this is the slide. You tell me lung mein kya slide hogi? So blood is going backward, na? Backward. So there is more blood here in the pulmonary capillaries. In the pulmonary capillaries. Can you see this is a diagram of the lung? This is a diagram of CVC lung. Just a second. In this diagram, what you can see, what are these circles? These are alveoli. In the lung, we have alveoli. These are the alveoli. These are the air spaces. Normally, it contains air. These are the alveolar spaces. Give me a thumbs up. These are the alveolar spaces, right? Now, what else in the diagram you can see? In the diagram else, you can see these are the pulmonary capillaries. These all are pulmonary capillaries, and the background is interstitium. Apart from pulmonary capillaries or apart from alveoli, whatever background you can see, the background is the interstitium. Now, what is the problem? You yourself tell me what is the problem. The left ventricle is not contracting. This is the problem. So the blood is not going in aorta. It is going backward, and it is coming in the capillary. It is coming in the capillary. Can you see? There is more blood in these capillary because of the backward flow. Where are the capillary in this diagram? Where are the capillary? These are the capillary. So these all capillaries are dilated. All these capillaries, can you see? All of them are dilated. Some of them will rupture. They dilated and fluids come out of them and fluid get gathered here. Can you see? Okay, just a second. The fluid get accumulated in the background. Can you appreciate the pink color fluid in the background? I'm marking with yellow color. This is interstitial edema. This is interstitial edema. So there is interstitial edema on the lung. So from these capillaries, the fluid is coming out because inside these capillaries, there is more blood. Inside these capillaries, there is more blood that is coming out in the form of the interstitial edema. That is the first thing. So first thing, capillary are dilated. Number 1. Number 2, the fluid coming out of the capillary and causing interstitial edema. Number 2. Give me a thumbs up. Now, if the edema goes on increasing, the edema fluid will enter inside the alveolus. And can you appreciate here? If you can, do this appreciation. Please everyone. This edema fluid will enter inside the alveolus, and can you see the background here? Inside the alveolus also we have edema. This is known as alveolar edema. So first interstitial edema develops, then alveolar edema. It is the first stage is interstitial edema. In interstitial edema, the fluid is in the interstitium, but air spaces are empty. So patient don't have dyspnea. At this stage, patient don't come to you with dyspnea. When edema increases and it enters inside here also, inside in the interstitium also, so air is replaced now. In place of air, patient have edema. Patient have edema fluid in the lung spaces. So exchange cannot take place and patient can't breathe. Patient have breathlessness. That is known as alveolar edema. So first interstitial edema happens and then alveolar edema happens. Give me a thumbs up. Till now I taught you 3 things. I am coming on the 4th and the last one, which is most important. See now, the pulmonary capillaries are dilated. Does anyone have any doubt? No. From this pulmonary capillary, the fluid will come out. The fluid will accumulate in the interstitial space first. So patient first have interstitial edema. Now this interstitial edema will enter inside the alveolus and causes alveolar edema. That is the third thing. Capillary dilated, interstitial edema, alveolar edema. They take place in sequence. Now capillary will rupture. The last stage. Capillary will rupture. Can you see here? Some of the capillaries are rupturing. So inside the blood is coming out. Blood contains RBC. RBC also get rupture. So capillaries are rupturing. RBCs are rupturing. Hemoglobin is coming out. Hemoglobin. Can you see hemoglobin? Hemoglobin get converted into hemosiderin. See the sequence. Capillary rupture, RBC coming out. RBC rupture, hemoglobin coming out. Hemoglobin get converted into hemosiderin. And this hemosiderin is ingested by a macrophage. So all these cells are macrophage. In the cytoplasm of them, you can see the hemosiderin. So these are hemosiderin-laden macrophages. These are known as heart failure cells. So in the lung, we are having heart failure cells. What are heart failure cells? Now it is a misnomer. Heart failure cells are not present in heart. Heart failure cells are present in lung. In CVC lung. Why these are known as heart failure cells? Because they are coming in the lung because of left heart failure. That's why in the lung we have heart failure cells. The reason is heart failure, the left heart failure. So this is the complete story. Give me a thumbs up. So in my exam, in the diagram of CVC lung, I want to explain 4 things. Let me draw a normal lung. In a normal lung, what we have multiple alveoli. These are the alveolar spaces. Let me draw a few alveolar spaces in my exam. It contains air normally. Let me draw a few pulmonary capillaries. We are having these pulmonary capillaries. These all are pulmonary capillaries. And background is interstitium. It is empty. This is normal lung. Let me show CVC in this. If CVC occur, the blood accumulate in the capillary. All the capillaries are dilated. I will dilate the capillary. So first thing I will write capillary dilatation. Pulmonary capillary dilatation is the first thing I will write and draw. Number 1, I will write also, I will draw also. After that, the fluid will leak out from the capillary and accumulate in the background of the interstitium. It will accumulate here in the interstitium. The fluid is accumulating here in the interstitium. So second thing here, I will write interstitial edema, and I will draw also interstitial edema. Give me a thumbs up. Now this interstitial edema will enter inside the alveolus and patient have edema in the alveolus also. This stage, patient have dyspnea and patient will run to your clinic. Doctor, I can't breathe, do something, right? So the third stage is alveolar edema. It is followed by alveolar edema. It is severe edema. Give me a thumbs up, patient have dyspnea. And lastly, these capillaries will rupture. Okay. These capillaries will rupture. If they rupture, RBC come out. RBC will also rupture. So hemoglobin will come out. This hemoglobin will convert into hemosiderin. So the macrophages are there. Multiple macrophages are present in the lung. They are already present in the lung. They will ingest the hemosiderin. So hemosiderin laden macrophages are known as heart failure cells. Heart failure cells. Describe each finding, enumerate each finding, highlight each finding, draw the 4 findings, label the 4 findings in the diagram. Proper labeling. 4 mark question, 4 labeling. 4 mark, 1 mark for each labeling. Everyone give me a thumbs up. This is CVC lung. So in CVC lung, basically you have to show these 4 things in your diagram. Writing is not important. Drawing and labeling is more important. So the same diagram I tried to draw, which is shown here. Everyone give me a thumbs up. Everyone, jitne audience, itne thumbs up. So second prof students, basically I have found students have problem in drawing these diagrams in the exam. So it is not the thing you have to do rectification ki is diagram mein kitne alveoli. No, it is not necessary. Whatever the information is given, draw a square. Draw multiple alveoli, whatever amount of number you want to show. You can 2, 3, 4, 5, whatever. Draw some capillaries, then start showing pathogenesis, right? Dilate the capillary, then rupture the capillary, show the edema first in interstitium, then show the edema inside the alveolus, and then from the dilated ruptured capillary, take the hemoglobin out, convert into hemosiderin, and show these cells are heart failure cells, and label them properly. Label them properly. You will get full marks, right? So information should be correct. While checking the copy, we don't match your diagram with the book. We check what labels you have done, what labeling. It should be correct, and what pathology, the 4 things occur, na? You should be able to show the 4 things in the diagram. That's it. That's it. You will get full marks, whatever marks question is it. So drawing is important, and you use only 2 color pencil here, purple and pink. Lilac and pink color, and some red color can be used, but not use all other colors. So that is the thing. It is a rule in paper too. Don't use other pencils for diagram. Student use orange, you know, they use any maroon, other black colors. So we will not give you marks. We will not. It is the examiner also get a, you know, proper protocol for what you have to give marks, for what you don't have give marks. You draw proper diagram, but the colors are not normal. They are not pink, purple. Some other colors are there. So we will give you 0 marks. So please use these colors only for drawing diagrams. Show all the nucleus with purple color. Show the cytoplasm with pink color, right? So you have to see the color combination also, right? Give me a thumbs up. Shall I proceed ahead? So heart failure cells are misnomer. They are present in the lungs, but they are not present in heart. Still, they are known as heart failure cell because they are present in the lung in case of heart failure. And basically, these are hemosiderin-laden macrophages. So what are heart failure cells? Hemosiderin-laden macrophages. I am done with CVC lung. I am done with CVC lung. So in the gross, I learned one thing, brown induration of the lung. Yeah. What is the reason of brown induration? I said, you know, I will tell you baad mein. I will tell you later on what. Brown induration is due to hemosiderin-laden macrophages. Hemosiderin is brown in color. So in the entire lung, we have multiple hemosiderin-laden macrophages, which is giving brown color to the lung. So this is the reason for brown induration of the lung. So in gross, only one finding. In microscopy, the 4 findings I already taught you. Pulmonary capillary dilatation, number 1. Interstitial edema, number 2, alveolar edema, number 3, and heart failure cells, the most important, number 4. Show these 4 in a diagram, then you will get mark. You will write, I will give 0. You will draw, I will give you full marks. Give me a thumbs up. So this is gross microscopy. That's it. Coming on second, CVC liver. Shall I start CVC liver? Shall I start CVC liver? Give me a thumbs up if you are ready. So let me start. CVC liver gross. Gross may write one word. One word is nutmeg liver. What do you mean by nutmeg? It is present in Indian kitchens. It is a eatable. Maybe you are also eating it. I eat it. I consume it. Right. So what is nutmeg? Do you know the Hindi name of nutmeg? In Hindi, the nutmeg is known as jaifal. Do you have jaifal? Ask your mothers. They will tell you what is jaifal. So this is jaifal, if you have seen it, right? It looks like this, right? It is like this. If you cut, this is the cut surface of a jaifal. In Indian culture, it is in Hindu culture, it is used in pujas also. In a puja plate, we keep the jaifal also, right? So, and the powder is used in the milk. It is a milk powder. So milk becomes delicious if you add jaifal in that. So this is jaifal. It is known as nutmeg. This is nutmeg. By the way, why liver is known as nutmeg? Here, can you see alternate red, yellow, red, yellow, red, yellow, red, yellow bands here? The liver also have the alternate red, yellow, red, yellow. Can you see alternate red, yellow, red, yellow, red, yellow? That's why the liver is known as, compare this nutmeg with the liver. The liver is looking like nutmeg. I will tell you the reason of the red. I will tell you the reason of the yellow in microscopy. First, understand why it is known as nutmeg. Nutmeg is jaifal. Jaifal have alternate red, yellow, red, yellow, red, yellow. That's why the liver also have alternate red, yellow. That's why it is known as nutmeg. See this diagram? See this diagram. So that is the jaifal. You know, nutmeg. Now let me tell you the microscopy. Can you compare this with this? So that is gross. Coming on microscopy. In the microscopy, you tell me one thing first. Let me show you the diagram. Okay. This is a diagram of liver. This is a diagram of liver. How I explain you. Do you know the lobular model of the liver? Do you know the lobular model of the liver? Let me first show you the lobule now. So in the liver, we have multiple lobules, the hexagonal lobules. In the entire liver, you may be knowing it, there are multiple lobules. The hexagonal lobules are present in the entire liver. At the center of each lobule, we have a vein. We have a vein at the center of each lobule that is known as hepatic vein. Hepatic vein or central vein. At the center of each lobule, we have a hepatic or central vein. At the periphery, the 6 corners, we are having portal triad. We are having, I'm drawing only for one, but it is for all. I'm not drawing in all, right? The 6 portal triads. In each portal triad, we have one artery, the hepatic artery. We have one vein, the portal vein. It is not central vein. Central vein is here. This is portal vein, and one duct. This is bile duct. So in each, we are having the three here also, here also. I'm not drawing in all, it will take time. So this is the portal triad at the periphery. At the center, we have vein, and at the periphery, we have portal triad. This is the diagram of the liver. Now, whenever I draw the microscopy of a liver, it is a rule. Whenever I draw the microscopy of the liver, I will draw a box. I will draw a square for the microscopy. At one diagonal, I will show this. At one of the any of the diagonal, and at other diagonal I will show one of the portal triad. I will not show all four. I will not show all four. So here I am drawing portal vein here. This is my not portal vein. This is my central vein, the hepatic vein here, and I am drawing portal triad here. This is my portal triad containing the three things, right? This is my artery, this is my vein, this is my bile duct. Give me a thumbs up. So this is the thing I'm going to show you in the diagram. I will show you the diagram like this. At one diagonal, I will show you central vein. At other diagonal, there is portal triad, but you should have an imagination. This is not one. These are six, but in the diagram, I'm showing you only one. You got my point? Now you tell me, it is CVC liver. Why it is happening? Why it is happening? You tell me. It is happening in right heart failure. Now imagine the right heart is not functioning. The right ventricle is not working. It is not doing the systole. Where the blood will go? It will go in right auricle. From right auricle, it will go to SVC, IVC. And from SVC, IVC, it will go to the liver and accumulate in the liver, in all organs. Yes or no? So where the blood will accumulate? It will accumulate here, or it accumulate here, here. Where it will accumulate? It is going backward now. The blood is coming from SVC, IVC. SVC, IVC are veins. So it will accumulate in hepatic vein. So this one is congested. These three are normal. This one is dilated, congested and rupture. Like in the CVC lung, first I have done the dilatation of pulmonary capillary and then I have done the rupture of pulmonary capillary. In the same way, CVC liver, first I will do the dilatation of central vein and then I will do the rupture of central vein. I will not do anything to the portal triad. That's what I want to explain you. You got my point? See this diagram which is given in Hirschman. Beautiful diagram. So in this diagram, at one corner you can see a central vein. This is hepatic vein, central vein. It is ruptured. It is ruptured. Can you see the blood coming out of it? It is ruptured. And at other corner, other diagonal, see the portal triad. Beautiful portal triad. Can you appreciate the portal triad? In this portal triad, appreciate the three things. What are the three things? I guess this one is artery, this one is vein, and this one is bile duct. Right? And this is the portal triad. It is normal. There is no problem in that. It is none of them is ruptured. It is intact. But this one is ruptured. Can you see? And can you see the row of hepatocytes connecting them? There is row of hepatocytes connecting them. Give me a thumbs up if you are getting what I am explaining you. You are getting my point. So this one is dilated. This one is ruptured. Because it is ruptured, the blood is coming out. You can appreciate the blood is coming out. That blood is impure. The blood is impure inside. It is a vein. Impure blood is coming out and the hepatocytes in this portion, they will undergo necrosis because of the impure blood. This necrosis is known as hemorrhagic necrosis. And these hepatocytes look red in color. They are necrosed, they are red in color because here is bleeding now. Bleeding ki wajah se this portion is red. This portion of the liver is red because of the bleeding. It is ruptured. Bleeding is there. So this portion, the hepatocyte undergo necrosis because of the impure blood. This is known as hemorrhagic necrosis. And this portion is red. Now this portion, these are the hepatocytes. In this portion, they are red. They are necrotic, hemorrhagic necrosis. These hepatocytes, which are near portal vein, not central vein. These are present near portal triad. These hepatocytes are not necrosed. They are not red. If you see their cytoplasm, if you see, they are having fat inside them. Fat. They have fatty change inside them because of which these are yellow. So the hepatocytes in this portion near portal triad are yellow because of fatty change. And the hepatocytes near central vein are red in color because of hemorrhagic necrosis. This gives the alternate red, yellow, red, yellow, red, yellow. Give me a thumbs up. What's the reason of red? What's the reason of red? Hemorrhagic necrosis. What's the reason of yellow? It is fatty change. Let me draw the same change in a lobule. You will have a better understanding. See, let me draw 3-4 lobules only. Who will tell me the lobule ke center mein kya hota hai? What is there in the center of the lobule? What is there in the periphery of the lobule? Let me draw a few of them. You will have a better understanding. The alternate thing, the nutmeg appearance. So at the center of each of them, I will draw a central vein. This is the central vein. At the center of each of them, I am drawing a central vein. At the corners of each of them, these are the portal triad containing three things. I am not drawing in all of them. They all contain three things, you know. So these are the portal triads containing three things. You got my point. Now, the central vein ke aaspaas ke hepatocytes, they are red in color because of hemorrhagic necrosis, because the central vein is ruptured. All the central veins are ruptured. Because of bleeding, impure blood, these hepatocytes undergo hemorrhagic necrosis, and these all are red in color. But the hepatocytes near portal triad, they are yellow in color because of the fatty change. See, appreciate the alternate red yellow, and this appearance is known as nutmeg appearance. Appreciate it. Give me a thumbs up. Will you be able to write, explain, understand and draw in your exam? This is nutmeg. Alternate red yellow, red yellow, red yellow. So red is the centrilobular hepatocytes. The central hepatocytes are red because of hemorrhagic necrosis. The red color is due to hemorrhagic necrosis. And the peripheral hepatocytes, which are near portal tract, the peripheral one are yellow in color because of because of fatty change. So that's it. That you have to write. So write only two things in your explanation. Number one, the centrilobular hemorrhagic necrosis ki wajah se it gives red color. And the peripheral zone hepatocytes show fatty change, that's why yellow. Red, yellow, red, yellow, red, yellow, nutmeg. That's it. I am done with the liver. I am done with the CVC liver. So try to draw the diagram, right? So in the lung, we have shown 4 changes in the diagram. So in the diagram, we have shown pulmonary edema, pulmonary dilatation, the capillary dilatation, interstitial edema, alveolar edema and heart failure cells, right? Here in the liver, only 2 things. The central one are red in color because of hemorrhagic necrosis. The peripheral one are yellow in color because of fatty change, and the combination is nutmeg. That you should be show. Don't write. Show it in a diagram. After showing, if you have time, describe it. Otherwise, in the diagram, proper labeling is more than sufficient to get marks. In your university exam, I'm talking about. Coming on the last, CVC spleen. CVC spleen. Give me a thumbs up. Shall I start CVC spleen? I must start. CVC spleen, you know normal spleen समझो भाई. Okay, gross तो समझ लो, gross में grey tan color. So nothing important basically in gross. Grey tan color spleen become grey tan color. This is spleen. You can appreciate the grey tan color, right? This is normal spleen. First understand normal spleen. Normal spleen में what is happening? Can you appreciate spleen have a capsule? Inside the spleen we have 2 things. Let me take a blank page. The red pulp and the white pulp. Can anyone tell me what is red pulp, what is white pulp? This is spleen, the capsule of the spleen. Inside the spleen, we have follicles of the lymphocytes. The lymphocytes are arranged in circular manner and they form follicles like this, the circular follicles. So these are the follicles formed by the lymphocytes. They are multiple. Inside of each of them, multiple lymphocytes are there which are arranged in circular fashion. These are the follicles. This is white pulp. This is white pulp. And in between the follicles, we are having blood vessels, capillaries. These are known as sinusoids. This is red pulp. So in the spleen, we are having red pulp. This is the capillary and we are having white pulp. You tell me CVC spleen kyun hota hai? Why it happens? I taught you, it happens in right heart failure. Imagine again the diagram of the heart. Right heart failure, imagine I have shown you that typical diagram many times. Right ventricle not pumping. Imagine the blood is not going ahead. Where it is going? Backward. Where it is going? Right auricle. From the right auricle, it is going to SVC, IVC. From SVC, IVC, it is coming to the spleen. So it will accumulate in the spleen. You tell me spleen mein which portion will be dilated? Red pulp or white pulp? Because of backward flow of right heart failure, which pulp is dilated? The red one or the white one? In the backward flow, blood is coming. So the red pulp will be dilated. Yes, common sense. White pulp will normal, right? So see the diagram of the spleen. In the diagram, you understood red and white pulp. The 2 pulps are there. So the first thing, this is the diagram. Can you see the red and white pulp? Beautiful diagram. Can you see this is the capsule? This one is the capsule. The follicles, this follicle, this follicle, this follicle, this follicle. The follicles are the white pulp. And can you appreciate the blood vessels? This is red pulp. Can you appreciate the red pulp is dilated? Number 1, you have to show congested sinusoid, that is red pulp dilatation. So red pulp is more as compared to white pulp. Give me a thumbs up. That is the first thing you have to show. Some of them will rupture as usual. Some of them will rupture. Can you see? If they rupture, RBC come out. RBC will also rupture. Hemoglobin will come out. Hemoglobin will convert into hemosiderin like the lung. So this hemosiderin along with fibrosis, is known as gamma antibody. It is known as gamma antibody. So this is the diagram of the spleen. So in the spleen, if you want to draw the diagram in your exam, first always draw a square. Right? Inside that square, show the capsule of the spleen. This is the capsule of the spleen. Inside this, draw some white pulp. Draw the follicles here and draw multiple red pulp. Red pulp is, it is enlarged. You should be able to show कि red pulp ज़्यादा है, white कम है. It is enlargement of the red pulp, not white. White pulp is normal. Red is more. Some of them is dilated, some of them is congested and ruptured. And this rupture is Hemoglobin. Hemoglobin converted into hemosiderin. Along with fibrosis, it is known as gamma gandhi. That's it. That's it you want to show in this diagram. Give me a thumbs up. And these are the trabeculae coming out of the capsule. Give me a thumbs up. So only two things you have to show. Number one, red pulp is enlarged, not white pulp. Red pulp is enlarged, number one. And number two, gamma gandhi. What are gamma gandhi? This is the definition. Some of the hemorrhage along with fibrous tissue. And in the hemosiderin pigment, this is known as gamma gandhi. That's it. So I am done with the three things. I'm done with CVC lung. The most important point is heart failure cell. I'm done with CVC liver. The most important point is nutmeg liver. I'm done with CVC spleen. The most important point is gamma gandhi. Will you be able to draw three diagrams? I wish if I have time, I can draw the three diagrams again. CVC lung, CVC liver and CVC spleen. But again, it will take 5 to 10 minutes. So you do by your own. So I'm done with the three CVCs. So my second topic CVC is also completed. Everyone give me a thumbs up. Shall I come on the next topic? Shall I come on the next topic? Till now, we have completed two topics. We have completed edema for the 5 marks, 20 marks. We have completed CVC, the three CVCs. CVC will never be a very long question, right? It will be one of the organ, lung, liver, spleen. लेकिन एक CVC हमेशा आता है exam में. It is very common to be coming in exam. You should be able to draw CVC. Drawing is important. Writing is not important. Again and again, I say the same thing. Everyone give me a thumbs up. Is it done? Shall I start the next chapter? Shall I start? The next chapter is thrombosis, hemostasis and thrombosis. Okay, I will complete thrombosis mode. It will take another 15 to 20 minutes. I will complete it, right? So before teaching you thrombosis, I will teach you hemostasis. What is hemostasis? Just suppose I am having a cut here. Imagine I am having a cut here. So what will happen? I will start bleeding. Anyone having cut anywhere on the body, injury anywhere on the body, we start bleeding. What happens next? We bleed for the next 10 seconds, 20 seconds, 30 seconds, maybe a minute, maybe 1.5 minutes. After that, bleeding stops spontaneously. Why it happens? Why? There is a cut now. I'm having 5 liters of blood. All should come out in the next 1 hour. And patient can die in the shock. Why it is not happening? God has given a mechanism that is bleeding stops spontaneously after injury. So a clot is formed here. The clot is sealing the site of injury. The site of injury is sealed by a clot, right? It is physiology. It is not pathology. It is not a disease. Whenever we have injury, clot is formed and it is for our benefit. If clot is not formed, I will bleed. All the blood will come out and patient can die. Patient can go in hemorrhagic shock and the person can die, I can die, right? But this doesn't happen. We all have a physiological mechanism inside us, that is formation of clot at the site of the injury, right? This is a beneficial for us. God has given this mechanism to us to prevent the bleeding at the site of the injury, the clot formation, the clot. So first a primary clot is formed, which is temporary, and then it is stabilized by secondary clot. So ultimately secondary clot seals the site of the injury till healing take place. After few days, few hours, here healing will take place and skin will come normally. The cut is sealed. Then the clot which is formed, it will dissolve after that, after healing take place. So it is a protective phenomenon. This is known as hemo. Hemo matlab blood, bleeding. Stasis. Stasis means stop the bleeding. To stop the bleeding, to stop. Stasis means stop. And hemo means bleeding. To stop the bleeding, God has given this mechanism to us, and we are thankful to the God that the God has given this mechanism inside all of us. We don't have to think. We have injury, we don't bother, oh my God, all the blood will come out, what I do. No, you don't bother. You just press it, okay, for a while. But whether you press it or you do not press it, ultimately it will seal. It is for the psychological, okay, you press it. But if you even don't press it, it will seal. It will seal, right? So whether you bother or you don't bother, whenever you have injury, some blood come out and then it automatically seal because of the mechanism hemostasis. It is beneficial, it is physiological, it is not a disease, and it is for good of humans, right? Now, let me draw a blood vessel to show you this, right? Imagine this is the blood vessel and here is the site of the injury, right? You can see the endothelial lining. Right, this is the site of the injury, right? What I am talking, a clot will form. Clot is formed by the platelet. So this is a platelet, they are coming here and they are forming a clot. This clot is primary clot. The platelet is forming and sealing it. Otherwise, blood will come out. Now, blood will not come out because the site is sealed. But this is a temporary clot. It is formed by the platelet known as primary clot. It is temporary. It will again rupture if it is not stabilized. For doing its stabilization, the clotting factors will come in role. We have 12 clotting factors. Factor 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. You have read this all, right, in the physiology. So factor number 1 is fibrin. All the factors are present in the blood. Fibrinogen is the first factor. all of them are inactive. So a cascade will come in the role, intrinsic, extrinsic pathway. Ultimately, factor 1 is get activated, that is fibrin, and fibrin will form a wiring. It will do a wiring over the primary clot. Now it is stable and it is known as secondary clot. It will not rupture now. So first primary clot immediately formed to stop the bleeding. But primary clot will hold only for next few hours. If in the next few hours secondary clot is not formed, it will rupture and bleeding start again. So within next few hours in the blood, the coagulatory cascade come in role and the fibrinogen do the wiring of the primary clot, uske upar pura wiring kar dega. So it will become stable, now it will not rupture. So ultimately secondary clot and it is sealed. Now the healing will take place. After healing it will dissolve. Give me a thumbs up. Give me a thumbs up. You will say, ma'am, why you are telling all this to us? We have read this in physiology. I know you have read this in physiology and this is known as hemostasis. Have you ever imagined a situation there is no injury? See, it is intact. The blood vessel is intact. There is no injury. There is no injury. Still a clot is formed. What it is known as? Is it good? No, this time it is not good. It is physiological? No, it is not physiological. It is pathological. It is a disease and this is known as thrombus. So mechanism is exactly same. First a primary clot is formed made up of platelet. Then a secondary clot is formed made up of fibrin. But the only difference, it is without injury. So it is without injury and it is known as thrombus. So this is known as thrombus and this is known as hemostasis. Hemostasis. You got my point? Here also primary and secondary clot are formed. Primary is made up of platelet, it is temporary. Secondary is stabilization of the primary by fibrin. Here also the same two things are there. So mechanism of thrombosis is same as that of hemostasis. It is physiological and it is beneficial. It is for the good of humans, right? This one is a disease. It is pathological, right? And it is harming the humans. It is not benefiting. How it is harming? If there is a clot here, if there is a thrombus here, this blood vessel is supplying blood to our organ, na? So constantly it is present here. So the blood to this organ is compromised. So ultimately this organ will have ischemia and this organ will have coagulatory necrosis because the blood flow is obstructed. So it is producing a hindrance. Without injury it is coming. Iska koi kaam hi nahi hai. Free mein aa gaya, right? Or it is producing hindrance. So it is a disease. It is known as thrombosis. Give me a thumbs up. So that is the definition of thrombosis. Thrombus is formation of clot without injury. The word to be picked here is without, right? If the clot is formed with injury, it is not thrombus, it is hemostasis, right? So I will teach you thrombosis later on. First, I will teach you the steps of hemostasis because the steps of hemostasis are exactly same in thrombus, only difference it is without injury. Give me a thumbs up if you got it. Give me a thumbs up. So that's why I have written two things here, hemostasis and thrombosis. So what is hemostasis? Hemostasis is a physiological phenomenon. Yes, it is a physiological phenomenon that is bleeding is stopped after injury, right? By platelet and by coagulatory system, right? It is beneficial. There are 4 steps in hemostasis. The same 4 steps take place in thrombosis also. So first study the 4 steps, right? How does it take place? So the first step is arteriolar constriction. See the diagram. As soon as patient have injury, can you see blood vessel? See the endothelium is intact. Ye to pura intact hai. Intact, everywhere it is intact. There is an injury here. This is the site of the injury. I guess this is, and here also it is intact. Can you appreciate the site of the injury? At that site, there is vasoconstriction. So that blood यहाँ पे आएगा ही कम तो bleeding कम होगी. So as soon as I am having a cut here, the point I am having a cut, that portion of the blood vessel is vasoconstricted. So that less blood coming here, less bleeding, right? This is transient, the first change. Give me a thumbs up. You can appreciate the vasoconstriction here. Appreciate the vasoconstriction of this portion as compared to other portion. So that is vasoconstriction. Then primary clot is formed. After vasoconstriction, primary clot formed, then secondary clot formed, and in the end, after healing, the clot will dissolve. So these are the 4 steps. Primary clot made up of platelet, right? I will explain you how primary clot is formed. So coming on the primary clot. Primary clot is made up of platelet, as I have told you. So see, there are 3 steps. I will explain you all. Can you see this diagram? In this diagram, can you see? These are the platelets. The green color are the platelets. So this is the site of the injury. You can see this is the site of the injury, and everywhere else endothelium is continuous. Endothelium is discontinuous here, so this is the site of injury. So in the blood we have platelets, RBC, WBC. Platelets, whatever are going, they will come here and they will form a row. They will form a row. First row of platelet, which is forming a bond with the subendothelial tissue. The first row of the platelet, which is forming a bond with the subendothelial tissue, this is known as platelet adhesion. This is platelet adhesion. Formation of bond between the platelet एंड सब एंडोथेलियल टिश्यू दैट इज कोलेजन, राइट, सब एंडोथेलियल टिश्यू के साथ बॉन्ड बना रहा है. प्लेटलेट एडहेशन, एक रो बन गई, एक रो, द फर्स्ट स्टोरी, फर्स्ट रो इज फॉर्म्ड. नाउ दीस प्लेटलेट विल secrete granules. Can you see the granules? They will secrete the granules. There is an emergency, please all platelets come here, we require more help, please come the backup. पहले प्राइमरी फोर्स पहुंच गया, उन्होंने एक सील बना ली, द प्राइमरी रो इज गोइंग एंड इट इज फॉर्मिंग वन रो, सो दैट ब्लीडिंग इज स्टॉप, कुछ तो रुके, एंड दे आर कॉलिंग अदर्स, प्लीज देयर इज एन इमरजेंसी, देयर इज अ इंजरी, देयर इज अ ओपन एरिया, वी हैव टू सील इट, प्लीज बैकअप कम, एंड दे आर कॉलिंग द बैकअप. फॉर कॉलिंग द बैकअप दे आर secreting granules from them. All of the platelets secrete granule. This is known as platelet activation. Activation means they secrete granule. After secreting granules, wherever platelet present in the entire body, all will gather there, so that all the platelet will accumulate over platelet, platelet over platelet, and they form multi-story, you know, one behind the other. So platelet with platelet, formation of bond with platelet is known as aggregation. So three things happens one by one: platelet adhesion, platelet activation, platelet aggregation. Give me a thumbs up. Platelet adhesion, platelet activation, platelet aggregation. You got the difference between adhesion and aggregation? You got the difference? Platelet adhesion is the formation of bond between platelet and subendothelial tissue, the first story. The first story. Activation is the release of the granules to call for the backup. More force, we require more force. And aggregation, when more force is occurring, so platelet over platelet, platelet over platelet. So formation of bond between two platelets is known as platelet aggregation. So different receptors are there, and ultimately the primary clot is complete, right? So three steps are there. As I've told you, now see the beautiful diagram from the Hirschman. This was from Robbins, and this one is from Hirschman. You can see here in this diagram, this is the blood vessel. Appreciate the blood vessel. See the endothelial lining. It is continuous, 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 here continuous, but this portion is discontinuous. So this is the site of injury. Always first appreciate the site of the injury, right? At the site of the injury, this is the first platelet coming and sealing here. So bond is formed between the platelet and the subendothelial tissue. So this platelet is showing adhesion. This platelet is showing adhesion. Now it will secrete granules and call other platelets for the backup. Now other platelets are coming, this one and this one. They are forming bond between platelet, 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 platelet. So these two platelets are showing aggregation, aggregation. Give me a thumbs up. Give me a thumbs up. Things are very easy if you understand them, right? For adhesion, can you see the platelet? These are the red color receptors for adhesion. Name the receptors, right? These receptors are forming bond with the subendothelial tissue, but there is a bridge, the green color bridge. The name of the bridge is von Willebrand factor. The platelet cannot directly form the bond with subendothelial tissue in adhesion. It requires a communicator in between, the bridge in between. The bridge is von Willebrand factor. So von Willebrand factor requires for adhesion. Give me a thumbs up. Now the name of the receptors is GP, glycoprotein 1A2A. Glycoprotein 1A2A, the red color receptors, which are forming bond between the platelet and the subendothelial tissue via von Willebrand factor. The receptor is 1A2A, right? And see the another receptor here, the brown color receptors. The receptors which are required for forming bond between platelet and platelet. These receptors are GP2B3A. It is glycoprotein 2B3A. ये 1A2A, 1A2A, ये 2B3A, right? Now there are two diseases. Barnold-Solier and Glanzmann. Okay, if God, have you ever thought if God has not given these receptors to the platelet are present in the blood. Imagine a human inside which platelet are there, but the receptor over these platelet are not present, these receptors, right? So what will happen whenever this person have injury? So platelet will come, they try to adhere, they try to form a bond between the subendothelial tissue and the platelet, but they don't have receptor, so they can't show adhesion. They can't show adhesion, and bleeding continues. This disease is known as Barnold-Solier syndrome. It comes for 2 marks. Barnold-Solier syndrome. Imagine another situation. The patient is having a platelet in which these receptors are absent, 2B3A. 1A2A are present, but 2B3A are absent. So the platelet, the first row will be formed, but subsequent rows will not form. Platelet can adhesion, but platelet cannot show aggregation. Granules will go, they will call the force, but force cannot bind with one another, right? So platelet cannot bind with platelet. This disease is known as Glanzmann syndrome. Glanzmann syndrome. It is a defect of aggregation. So Barnold-Solier is a defect of adhesion, and Glanzmann syndrome is a defect of aggregation. These are 2 mark question. Give me a thumbs up, everyone. Are you watching? Are you awakened? Have you understood the diagram? So that is the thing. So, and this is activation. In between the two, we have activation. Granules are coming out. All the granules are coming out. So platelet adhesion, we require these receptors GP1A, 2A, and we require a bridge von Willebrand factor. Adhesion के बाद activation. The second is the activation. You can see the activation. Oh, activation means the granules secrete the things and they will call the force. They will call the force. They will call. And in aggregation, we require another receptor that is 2B, 3A, and they form bond between adjacent platelet and platelet. So I taught you two diseases here. They are not written here. They will be ahead. Bernard, Solier, and Glanzmann. Primary clot is complete, but it is unstable. You want to stabilize it. For stabilization, you require a fibrin. You got my point? So how fibrin will come in role? So fibrin will come in role like this. So there are two pathways. Intrinsic pathway that you have studied in physiology in your childhood. Yes or no? In your childhood means in your first year MBBS. This is intrinsic pathway. This is extrinsic pathway. You may be knowing it now. Okay. If you don't know it, for those who don't know it. So in intrinsic pathway, the first factor activated is factor 12. 12 leads to activation of 11. 11 leads to activation of 9. 9 leads to activation of 8. Right? 8 leads to activation of 10. 10 in presence of 5 leads to activation of 2. 2 leads to 1. Please learn the sequence. Learn इसी sequence में याद करना. Right? 12, 11, 9, 8, 10, 5, 2, 1. ये ऐसा रटा हुआ होना चाहिए इसी sequence में. आगे पीछे नहीं करना है. This is intrinsic. Right? In extrinsic, the first factor activated is factor 7. And it directly activates 10. 10, 5, 2, 1. So this portion is common. You may be knowing this is common pathway. This one is common pathway. This one is extrinsic pathway. And this one is intrinsic pathway. This one is intrinsic. Everyone give me a thumbs up. Now whatever is the pathway, उससे मुझे मतलब नहीं है. Intrinsic हो and extrinsic हो. End result is same. Activation of one. Whether it is this, whether it is this. What is the end result? मुझे उससे मतलब है. End result क्या है? Activation of one. In the blood, in my blood, all 12 are present. In your blood also all 12 are present. But they all are inactive. If we have a cut, they will get activated. So it is not all 12 get activated suddenly. All 12 are line से खड़े हैं और सब activate हो गए. No, they will activate in the sequence. If I have a cut, the first factor activate is 12. 12 leads to 11. 11 leads to 9. 9 leads to 8. 8 leads to 10, 5, 2, 1. In the end, 1 will be activated. And this is known as cascade. The meaning of the cascade, you got it? One leading to the activation of other. The other leading to the activation of other. Other leading to the activation of other. This is the meaning of cascade. You got my point? The things are very simple if you understand them. So all are present in my blood. In my blood, in your blood, we have all. But all are inactive. If we have a cut, this is the sequence. Either this or this, and ultimately one is activated. This one, the name of this one is fibrinogen. It will convert into fibrin. So active form is fibrin. So ultimately end result fibrin ban gaya. Chalo, fibrin ban gaya. So whether this or this, ultimately fibrin is formed. So where is my primary clot? Let me show you. This was the green color platelets are the primary clot. Can you see this row? Can you see the first row? This is showing adhesion. Because here the bonds are formed between platelet and subendothelial tissue. Can you see? Can you see the subsequent two rows? Uske upar ki dono rows. Okay, this one and this one. This is showing aggregation. Because bonds are formed between platelet and platelet. Right? So adhesion, activation, aggregation, primary clot is over. But this is unstable. If you don't stabilize it, it will again rupture within few hours. So for stabilization, we bring fibrin. So in the blood, factor 1, 2, 3, 4, 5, all were there. We have activated them in a sequence that is intrinsic, extrinsic pathway. Ultimately factor 1 is activated. The name is fibrin. Fibrin is there in the blood, which is active now. This is yellow color, shown by yellow color in this diagram, and it is forming a wiring over this. If you can appreciate and zoom the diagram, iske upar wiring aa gayi. Now this clot, the platelet with fibrin, it is known as secondary clot, and it is stable now. It is stable now. So for secondary clot, you require fibrin. Fibrin is factor number 1. Give me a thumbs up. So secondary clot is formed. Now in the end, when the healing completed, we cannot keep the clot forever now. When the healing is completed, we will dissolve it. We will dissolve it, so that is the last step. So hemostasis mein we are having 4 steps. What are the 4 steps? Can you tell me the 4 steps? So the first step is vasoconstriction. The second step is primary clot formation with the help of platelet adhesion, activation, aggregation. तीनों दिख रहा है इस diagram में. Beautifully, you can see this is adhesion, this is activation, the granules are coming out, and this is aggregation, platelet over platelet, right? And after that is secondary clot is formed. See the yellow color here, the wiring, the fibrin. So fibrin is coming and that is stabilized. And lastly, the clot is dissolved. The first clot, it is dissolved. Now let's start thrombosis. If you got hemostasis ka steps, the steps are same for the thrombosis also. Let me start thrombosis. Who will tell me that hemostasis will not come in your exam? If you're a first prof student, it can come in physiology. It will not come in pathology. So you will say, ma'am, why you have taught us if it is not coming? So if you don't know the step of hemostasis, how you can answer thrombosis? The steps are same now. Isme bhi wahi 4 steps hain. those 4 steps only. Primary clot, secondary clot, same उसी mechanism से बनेगा. So you can cut copy from there and paste here, right? In the thrombosis, the steps are same. You got my point? That's why I taught you. So it is not wastage. You have to write everything here. So tell me the definition of thrombosis. Thrombus is the formation of blood clot, but without injury. Without injury. In a integrated blood vessel, right? Inside the blood vessel without injury. It is pathological. It is not physiological. The clot is known as thrombus. And without injury, it is forming. With injury, it is known as hemostasis. Without injury, it is known as thrombosis. So that is the thing. Can you appreciate here in this diagram? This is a clot. And without injury, it is forming. It is thrombus. So hemostasis and thrombosis mein yahi difference hai. Hemostasis is physiological. It occurs after injury. After injury. And thrombosis is pathological. It occurs in uninjured blood vessel, unruptured blood vessel. So that is pathological, that is harmful. This one is good, this one is harmful. So can you see? Beautiful diagram. Can you see the red one are the platelets? Can you see? And can you see the yellow wiring? Appreciate the yellow wiring is the fibrin. So primary as well as secondary clot both are shown in this diagram in an unruptured blood vessel, right? So that is causing obstruction. So you can see the same diagram here. First primary clot is formed and then secondary clot is formed. So this is thrombus. Till thrombus is attached to the blood vessel, it is thrombus. It is unruptured. It is uninjured. There is no injury. It is known as thrombus. Once it dissociate from the vessel wall and move freely, it is known as embolus. My next topic is embolus. So embolus are formed from the thrombus. So पहले hemostasis समझो, hemostasis से thrombosis समझो और thrombosis से फिर embolus समझो. Embolism. You got my point? So that is thrombus. So what is the pathophysiology? Now the point here, why it occurs. Why it occurs? The point here, without injury, why it is forming? Without injury, there is no injury now. If it is occurring after injury, it is understable. But without injury, it क्यों बन रहा है? So there are 3 reasons for that. You have to learn the 3 reasons. It is known as virtual triad. There can be endothelial injury, not throughout the injury. Inside only endothelium is injured, but complete through and through cut nahi hai. There is no bleeding. So endothelial injury can be the first cause. The second, abnormal blood flow, blood stasis is there. That can be the second cause. And third, hypercoagulation. That can be the third cause, right? Because of 3 causes, even without injury, the clot is formed, which is known as thrombus. And this is known as virtual triad. What it is known as? So tell me, virtual triad alag se aata hai, 2-mark question, 3-mark question. What are the 3 things in the virtual triad? It is endothelial injury, blood stasis, and hypercoagulation in the blood. So that is pathophysiology. You understood the definition, you understood the pathophysiology, and you can explain the mechanism, the steps. The steps are same. The primary clot, the secondary clot. Primary clot में platelet में again 3 चीजें, platelet adhesion, activation, aggregation. और secondary clot में वही 2 चीजें, the intrinsic pathway, extrinsic pathway, common pathway, and ultimately fibrin will stabilize. So steps are same. So I'm skipping the steps. Just a second. I'm skipping the steps and coming ahead. You can copy the steps. I have already taught you the 4 steps. You just copy from there. After that, coming on the types. Types of thrombus. What are the types of thrombus? Just a second. What are the types? There are 3 types of thrombus. If they are forming in the artery, okay. If they are forming in the artery, it is arterial. If they are forming in the vein, these are venous. And if they are forming in the heart, they are cardiac. So there are 3 types: cardiac, artery, and venous, right? So that is the thing. You can see grossly. You can see a arterial clot formed inside the artery, a venous clot formed inside the vein. You should know the differences between them. Let me show you the differences. Directly differences का table दिखाती हूँ. Just a second. So this table is very, very important. The type of the thrombus. So arterial thrombus formed inside the artery. Venous will form inside the vein. I will draw the diagrams for you. First understand the table, then I will draw the diagrams for both of them. Arterial thrombus. I taught you 3 reasons now. Virtual triad में 3 reason क्या बताया मैंने? What I taught you. The first reason is the endothelial injury. Basically, it is due to endothelial injury, the arterial one. But the venous one is due to stasis. It is stasis of the blood. So endothelial injury, stasis, and hypercoagulation. So endothelial injury basically leads to the thrombus formation in artery, and stasis basically lead to the thrombus formation in the vein. That is the first difference, right? In artery, active blood flow is there. In vein, passive, sluggish blood flow is there. So these thrombus are formed in active blood. These thrombus are formed in sluggish blood. Name the arteries in which they are formed. So coronary artery and cerebral artery, artery of the heart and the brain. These are most commonly involved. Name the veins of the leg, the deep leg veins. The leg veins are most commonly involved here. Now, retrograde or antegrade का मतलब समझो. Okay, I will draw a diagram for the retrograde and antegrade. Let me draw. This is artery, and let me draw. This is vein. This is vein. I will draw thrombus inside each of them. The mechanism is same. Right? So platelet adhesion, aggregation, activation with fibrin deposition. So primary clot along with secondary clot. I've already explained the mechanism. So it can be formed in the artery and vein without injury. It is without injury, right? So what differences I told you here? What is the, here the blood is flowing. See the direction of the blood flow. Everyone see the direction of the blood flow. So arterial one, it propagates and it grows opposite direction to that of blood flow. This is known as retrograde. This is known as retrograde propagation, right? And this one grows in the same direction of the blood flow. And this one is known as antegrade propagation. So the propagation in the arterial thrombus is retrograde. In the venous, it is antegrade. You got my point? You got my point? Say yes or no. You got my point? So that is retrograde and antegrade. Here the most common reason is endothelial injury. Endothelial injury. Here the most common reason is stasis of the blood. Here these are formed in active blood flow. Here they are formed in sluggish blood flow. Here most commonly they are formed in coronary and cerebral artery. Here most commonly they are formed in leg veins. So these are the differences. Everyone give me a thumbs up. Everyone give me a thumbs up, right? So that is the thing, right? Here it retrograde, here antegrade. You got my point. The next is the lines of Zahan. What do you mean by lines of Zahan? The lines of Zahan are the alternate light and dark band. Lines of Zahan are present in artery, absent in vein. Can you see? This is a blood vessel. Appreciate the three layers, intima, media and externa. Can you see this one is intima, then media, then externa. In the lumen, can you see the thrombus? This one is the thrombus. Can you see this one is the entire thrombus attached to the wall, attached to the wall. In the thrombus, can you see light band, dark band, light band, dark band. The dark one is due to RBC. जहाँ जहाँ पे RBC आ रहे हैं वहाँ पे dark है. जहाँ जहाँ पे fibrin आ रहा है वहाँ पे light है. So alternate light dark bands are known as lines of Zahan. Lines of Zahan. These lines of Zahan are present in arterial but absent in, see the lines of Zahan, alternate light dark. These are present in artery. These are present in arterial thrombus, but these are absent in venous. That you have to learn. Here platelet layer is pale. It is light. It is alternate with dark RBC. So light, dark, light, dark, light, dark. That is the thing, right? So that is the thing. Here, yeah, one more thing. The arterial one are incomplete. They do not completely obstruct the lumen, and the vein one completely obstruct the lumen. Arterial one, you yourself tell what is the consequence of each of them. What is the consequence of each of them? Let me draw an organ. Okay, the final difference organ. Okay, this is the final diagram. You can draw if you wish. This is the artery for this organ, and this is the vein for this organ. I will draw thrombus in both of them, and you tell me the summary. So let me draw the thrombus with blue color. So this is the thrombus here, arterial thrombus. This is the thrombus here, venous thrombus. You tell me the summary. You tell me the points, the difference ke points. So here arterial thrombus, the main reason is endothelial injury. The main reason here is, what is the main reason here is? Stasis of the blood. Tell me the arteries, coronary and cerebral. Here the veins are the leg veins, right? Here lines of Zahan are present, alternate light dark. Here lines of Zahan are absent. This grow in retrograde manner. You understand? This is the flow of the blood, and they are growing in this manner, retrograde, opposite, retrograde manner, and they propagate in antegrade manner, the same direction, antegrade manner. So they grow in antegrade manner. Give me a thumbs up. Everyone give me a thumbs up. The next point. Now imagine there is the next point. These are incomplete obstruction. They cause incomplete obstruction, and these one will grow, and they cause complete obstruction. They cause complete obstruction. Give me a thumbs up. The last point. Now imagine there is obstruction in the artery. What will happen to the organ? Organ में क्या होगा? अगर artery से pure blood नहीं आ रहा, तो in the organ ischemia will be there. Organ is not getting pure blood. So here the result is ischemia. The end result is ischemia. And if venous thrombus is there, so pure blood is coming, but the impure blood is not leaving. Impure is not leading, and it is accumulating in the organ only. So this one lead to edema. So this is the end result. So arterial thrombus leads to ischemia, and venous thrombus leads to edema. So can you tell me the differences between arterial and venous thrombus? Yes, you all can do that. So tell me the differences between arterial and venous thrombus on these points. Tell me their pathogenesis, the main pathogenesis, right? Tell me their propagation, antegrade or retrograde. Tell me the examples in which artery they are common, right? Tell me the lines of Zahan, whether they are absent or present. Tell me whether they are complete or incomplete. And tell me the end result. The end result, the effect on the organ, you can say. If I'm missing some point, you can add it. So that is the thing. You can fill the table. Pathogenesis, here is endothelial injury. Here it is stasis. That is the pathogenesis. Propagation, this is retrograde. I have explained you. And this is antegrade. Examples, here it is coronary and cerebral. Here it is leg veins. These are arteries, these are veins. Lines of Zahan present, absent. Occlusion, it is incomplete, partial. Here it is complete. Here it is complete. So obstruction in artery leads to ischemia, and obstruction in a vein lead to edema. These are the main differences. Everyone gave me a thumbs up. Everyone. Now try to correlate the complete table. I have explained you. Draw the diagrams wherever necessary. Explain the points wherever necessary. Right. These are the types of the thrombus. Right. The last thing, fate of the thrombus. होगा क्या इसका? चलो बन गया है ना. आर्टरी में बना, वेट में बना, वेन में बना या हार्ट में बना, बन तो गया. There can be 4 possibilities in future. What are the 4 possibilities? If you are lucky, if the patient is lucky, with time it will resolve. It will resolve, it will decrease in size, and it will resolve. Resolution means it will decrease in size. In future, it is dissolving in the blood. If you are lucky. If you are unlucky, it will fix in size. It will fix in size, and calcification occurs over it, and it is fixing there. Fixed in size, that is organization. It will never increase, it will never decrease, the size is fixed. Calcification is there. If you are more unlucky, it will increase in size. It will propagate. It will propagate. If it is arterial, it will go retrograde, and if it is venous, it will go antegrade. It is propagating means increase in size. And last, it is detach. It will detach from its site, toot jayega, and it will flow freely. That is embolus is formed. It is converted into embolus. Multiple embolus are there. So four possibilities. It decreases in size, resolution. It fixes in size, organization. It increases in size, propagation. And it detaches from the site, embolism. So resolution, organization, propagation and embolism. These are the four possibilities. और क्या हो सकता है? या तो साइज में कम होगा, या तो बढ़ेगा, या तो उतना ही रहेगा, या तो टूट जाएगा. और क्या होगा? Right? There is no other possibility apart from these 4. You got my point? So we got the answers of these things. Yes or no? Yes or no? So if thrombus is coming in your exam for 20 marks or 5 marks, first write the definition. You know the definition. It is the formation of clot without injury. The word is without, right? Pathogenesis mein you draw Virchow triad. Virchow triad mein you know the 3 things of the Virchow triad. Draw that and draw the mechanism. How primary clot is formed. Explain the 3 things. What is platelet adhesion? What is platelet activation? And what is platelet aggregation? Draw the flowchart, draw the beautiful diagrams. Draw the secondary. Secondary कैसे बनेगा? Secondary clot. So there is intrinsic pathway, there is extrinsic pathway, there is common pathway. Ultimately factor 1 is activated, that is fibrin, that is stabilizing the platelet clot. So explain everything. It will take 2-3 pages to explain the flowcharts, diagrams, everything. So pathogenesis mein explain the primary clot, explain the secondary clot, and then explain the Virchow triad, the 3 things of the Virchow triad. So pathogenesis will be the biggest one. You can write 5 to 6 pages on pathogenesis, right? Then in the types, draw the difference between arterial and venous one. Draw the table. I have explained you the table with diagrams, flowcharts wherever necessary. In the fate, write down the 4 fate. It decreases in size, that is resolution. It increases in size, that is propagation. It is fixed in size, that is organization. Or it detachment is embolism. You explain each of them. Give me a thumbs up. So these are the headings under which you have to write your 20-mark long question for thrombosis. I am done. Summary is also done. Everyone give me a thumbs up. Everyone give me a thumbs up. Everyone means everyone. We are done. You can see the arterial and the venous one, right? Okay, fate is also done. I am done. So here I would like to stop. Today I have covered 3 topics. I have covered edema, entire edema for 20 marks. I have covered CVC of 3 organs. I have covered CVC lung, CVC liver and CVC spleen, right? In each of them I taught you the gross, the microscopy. Here microscopy, heart failure cells are the best to be described. In liver, the nutmeg appearance is best to be described, the alternate red and yellow. And spleen, the gamma Gandhi bodies have to be described. If you write these words, I will give you full marks. And you have to draw the diagrams. You have to show the findings in CVC. The 3 CVCs we have done today. CVC or CPC, one and the same thing. After that, we have completed the thrombosis for 5-mark or 20-mark question. So we have covered many small questions also, many long questions also. Still 2 topics are remaining in this. Embolism, it will take another 15 minutes, 15 to 20 minutes. And shock, another 15 minutes. So I need 30 to 45 minutes to cover these two topics, but currently I cannot continue it, so I'm stopping it. I don't have any further lecture today. I'm stopping right now. So there is no further lecture on the app today. As usual, after this I take the lectures on the app now. So today I'm not continuing on the app because my hours are limited on the app and they are going to be finished in the next few days, right? So I have to continue for the remaining whole month now. So okay, so that's it. So thank you very much for being with me. I really enjoyed teaching you. Hopefully same from your side also. How to go? Okay, there are few announcements for you about my further lectures. Just a second. Okay, let me announce my next lecture. So I'm taking my next lecture tomorrow. Tomorrow is my next lecture. I'm taking the lecture at what time? It is not from morning 8 AM as usual. So I'm taking the lecture at 12 PM. Tomorrow at this time I will start on YouTube only. I'm having only one lecture tomorrow on YouTube at 12 PM. Tomorrow, on high demand from most of the second Prof MBBS students, I'm taking a special lecture on complete oncology in the pathology. So I will cover all the tumors in one lecture. I will start with breast cancer. I will start with breast cancer. Then I will cover the liver. I will cover the kidney. I will cover the lung. And what else? I will cover the esophagus. I will cover the stomach. So these all tumors I am going to cover in tomorrow's lecture for the sake of writing in university exam in points. So 5 or 20 mark question you will get on the oncology. So main tumors I am going to cover tomorrow for university exam purpose of you, but that will be useful for MCQs also. Those who are attending for the NEET PG FMG, so they will also find many important points in that. So tomorrow's lecture is oncology. Oncology. I will start at 12 till 1:30 or 2. I will continue for 2 hours. Non-stop marathon will be there for 2 hours, 12 to 2. So thank you very much for being with me. And if you have any other thing, okay, amyloidosis, Sophie, I will try to arrange lecture on that. Okay. So okay, I will cover the topics. Please tag me on the Telegram. Whatever other topics apart from this you require from my side, from the second Prof subjects, please tag me on the Telegram, right? I'm available on the Telegram. I'm available on Let's Crack NEET PG, Telegram channel of Unacademy. Let's Crack NEET PG. This is the Telegram channel of Unacademy. I'm available on this group. Join this group and search me in the members of the group. I'm available by the name MedLife by Dr. Priyanka. So this is my Telegram ID. M capital L capital. MedLife by Dr. Priyanka. You will find me by this ID, Priyanka. And please, you can tag me and ask your doubts, and you can give your suggestions or request, whatever you say on the topics that is patho, pharma, micro you want from my side, apart from what I have already taught you. So if I can help you, I will definitely help you on those topics, and I will try to arrange lectures on that if many students are demanding the same thing, right? So thank you very much. And there are few announcements. If you are going to take Unacademy subscription till tomorrow, that is 19th of May, before 12 PM, you will get 20% extra discount if you apply my code Sachdev10. SACHDEV. Sachdev is my surname. Without space, it is 10. Sachdev10 is the code. If you apply on any subscription before tomorrow 12 PM, you will get 20% additional discount. So I request student, if you are planning to take any subscription, Plus, Iconic, Light, any subscription, please take it before tomorrow 12 PM. So you will get additional discount. After that, the price hike is coming. It is declared by the team. So you will not get these prices again. The price hike will be there. So that is the thing. Let me show you the various plans available with the team. We are having Plus subscription, in which you will get only Unacademy live and recorded lectures. These are the plans. We are having Iconic with us, in which along with Unacademy we will give you prep letter also. So these are the plans, right? We are having Light subscription, in which you will give you only test series, nothing else. So these are the plans. MBBS first year, we will give you anatomy, physiology and biochemistry. Only these 3 subjects, nothing else. So these are the plans. So whatever plan is required by you, suitable to you, it's your choice, it's your wish, according to your requirement, your wish and need. You can select your best plan for you. According to me, longer the plan, cheaper it is. So I suggest you, if you follow my suggestion, I advise you to take a longer plan if you're a first prof, second prof student. You can imagine if the free knowledge is such a thing, I'm teaching you only 10% or only 5% of your complete syllabus, right? So if you take the subscription for few months, the 19th subject will be done from the team. We are having best educators in our team, and as a team we cover all 19 subjects for your whatever thing you are preparing. You are preparing for university exam, we will do it. You are preparing for NEET PG, FMG, INICT, next USMLE, whatever you are preparing, we are having separate batches for that, right? So we cover all 19 subjects. So please believe, and you can take any subscription, and if you're going for 4 year, 3 year, 2 year, per month wise, it will be cost effective, but it's your choice. If you don't want to take risks and try it out, take as small as 1 month also, it is available. As small as 6 months is also available, so you can give a trial and you can extend if you like, right? And if you apply my code on any of them, the same code Sachdev 10, SACHDEV Sachdev 10, before tomorrow you will get 20% discount on all of these, and after tomorrow you will get only 10% discount, and prices will rise. So thank you very much. Bye bye. Study hard. See you all tomorrow 12 p.m. in the afternoon with complete oncology. I want all students back. Bye bye. Study hard and all the best, and thank you for giving your precious time to me. Bye bye.